We are live.
So, good evening, friends, and welcome to the second webinar on behalf of ARC AIOSC. As we had already conceived that most of the programs which the ARC unit webinar wing of the AIOS is going to do will be predominantly which are the topics which are going to be of day-to-day use in practical in your day-to-day practice. And with this intention, we have the second webinar of the series, which is the Oculoplasty Pearls for Comprehensive Ophthalmologist. I take this opportunity to greet Dr. Subhash Betaria, sir, who hails from our own city of Nagpur. He had his birthday yesterday, 75th birthday. So we wish all Dr. Betaria, sir, a very happy birthday and have a very healthy life for in coming years. And we would love to have him on our forum on and off whenever need be. And Dr. Kasturi, ma'am, also will be taking care of that. We are proud.
Thank you very much, Prashant. Grateful.
Thank you, sir. We also are very proud to have one of our teachers from Shankar Netralaya, Dr. Nirmala Madam, who is attending. Thank you, Dr. Kasturi Madam, for getting all the dons with us. And without now much ado, I invite all the speakers today for Oculoplasty webinar, who have joined with us, and Dr. Kasturi Madam to take forward, because we would not like to bore our other viewers with much of a detailed introduction beyond certain things. So over to you, Dr. Kasturi, for further proceedings.
Thank you very much, Dr. Prashant, and respected my teachers, my seniors and friends. And it's a great pleasure to welcome all the doyens of Ocuplasty. I really consider it a big honor, and thank you all of you for joining us. I'll give a very short introduction. So at the outset, I would like to welcome Professor Betaria, who is the Director and Head of Ocuplasty at Visitech Eye Center. He has a rich experience of more than 30 years at RP Center AIMS and has served as a professor and also the head of Ocuplasty there in All India Institute of Medical Science. He's a fellow of Ocuplasty and Orbital Surgery from Moorfields Eye Hospital, London, and is a member board of directors, International Ocuplasty Society in New York, USA. He has got numerous publications and awards to his credit. And I also like to welcome my mentor, Dr. Nirmala Subramaniam, who is a very senior plastic surgeon associated with Shankara Netralaya, Chennai since 1981. She completed her MBBS and MS General Surgery from All India Institute of Medical Science, followed by a MCH program. She had extensive experience in both oculofacial plastic procedures and in other plastic surgery, burns, hand surgery, microvascular surgery. Former professor and head of the Department of Plastic Surgery at Kilpauk Medical College, Tamil Nadu. And also she was a past president of Oculoplastics Association of India. I would like to welcome our co-chairperson, Dr. Lakshmi Mahesh, who is a nationally renowned ophthalmoplastic and reconstructive surgeon with 29 years of experience in the field and being a pioneer in ptosis and orbit surgery, has done extensive work in thyroid eye disease and lacrimal surgery, and she is one of the past president of...
Maybe I have a presentation also.
And currently associated with Chakra World Hospital. Grover sir, in its no introduction, he is a prominent name in the realm of not only oculoplasty and facial aesthetics, but also cataract, refractive, and ophthalmology as a whole. Alumnus of All India Institute of Medical Science, started his profession with MAMC way back in 1984. Lots of numerous publications, and also the recipient of the prestigious Padma Shri by the government of India, and also the FICO and the FIMSA, and also the prestigious Achievement Award at Episoppers at Chengdu, China. The Usha Singh, I think she'll be joining, a renowned professor, highly respected ophthalmologist, and she is a professor in PGI MER Chandigarh, one of the leaders of the Advanced Eye Center at PGI, and expert in retinoblastoma, and has cited in numerous research papers. So I have Dr. Shubhra Goyal as a co-moderator with me. She is an industry-recognized oculofacial aesthetic surgeon with over 18 years of experience, specializes in eye-based restorative therapy, one of the very few surgeons in India with dual long-term certified fellowship, one from Shankara Netralaya, Chennai, other from University of Wisconsin. And she is a pioneer in her field and a co-founder and CEO and the chief surgeon of the Clinica 5. So we have a little change in the program. First, I would like to welcome Dr. Feroz, who heads the Feroz P. Manjandavida, and she has the Department of Orbital and Ocuplasty at Horus Eye Clinic and Research Center, Bangalore. She also holds a very prestigious dual fellowship, one from L.V. Prasad and other from the Wills Eye Hospital, Philadelphia, USA. She is considered as one of the best, surgeon in and also ocular oncologist in the country, both nationally and internationally. And she was trained by Dr. Jerry Shields and Carol Shields, had done numerous work in retinoblastoma. Her expertise includes the orbit, eyelid, ocular surface disorder, dacryology, trauma, and aesthetic surgery. Over to you, Feroz.
Thank you so very much for this kind introduction. Really, really humbled to be part of this platform where obviously we have the doyens, the seniors here. Congratulations to ARC on organizing such a wonderful webinar. And of course, I'm sure that it will be a learning for us as well. I'm going to share the screen. So I hope it's visible now.
Yeah.
Yes.
Yes.
All right, perfect. Yeah. So thank you for choosing this particular topic, Dr. Kasturi. It's definitely interesting, and keeping in mind, the application of this particular topic among the comprehensive ophthalmologists, I would try to keep it really, really simple. It's about diagnostic biopsy in ocular adnexal and orbital lesions. Sorry, these are my affiliation and financial disclosure. So when we talk about diagnostic biopsies, we know various terminologies like imprint cytology, punch biopsy, incision biopsy, excision biopsy, and these are the common terminologies that we usually use. Now, when we talk about diagnostic biopsies in certain case scenarios, it is often therapeutic as well, and we'll come to the various case scenarios as well. So going on to part one regarding ocular adnexal lesions, where we would be covering orbital lesions as well. Now, when we come to these lesions in ocular adnexal tumors or lesions, this is a very straightforward clinical case where we have a basal cell carcinoma in figure 1. Figure 2, it's very classical clinical presentation of a yellowish nodule arising from the tarsus involving the lid margin, which is sebaceous gland carcinoma, and a lesion over the brow with a crater, which is in favor of a keratoacanthoma. So in these lesions, when we talk about the choice between incision biopsy and excision biopsy, it's very, very straightforward. Right, we go in for an excision biopsy following the protocols of ocular oncology principles with a wide margin, and that's what we do. So we have spoken about this in various platforms regarding the importance of frozen section as a standard of care in eyelid excision biopsy. And this is how we actually, excise the lesion in cancerous lethal eyelid malignancies, where we excise the lesion, and in and around the lesion, around 4 millimeters of margins is included. And the lesion is submitted for frozen section, where the pathologist would tell you whether the margin is positive or negative. So one, it is diagnostic, of course, confirmation of diagnosis of your clinical, decision and your clinical diagnosis, and therapeutic also. And as well as most important is diagnosis regarding how well the margin is cleared in these situations where the outcome will be, favorable or unfavorable depending upon the report. Now, this is also a very straightforward clinical case of a sebaceous gland carcinoma. But now, when we come about these situations, when you might have to slightly deviate in the management, where you might have to give a neoadjuvant chemotherapy to reduce this large lesion, where the complete excision may not be possible. In that situation, despite knowing clinically that it is a straightforward case of a sebaceous gland carcinoma, you would probably want to take an incision biopsy to prove that it's sebaceous gland carcinoma, because the patient is being sent to a medical oncologist for further evaluation and management. So then an incision biopsy also plays a role in large lesions like this. Now, we all know that inflammation versus neoplasia sometimes is a dilemma in eyelid lesions. And in most of these, comprehensive ophthalmologists might be seeing these lesions where it is kind of falling in place with a malignancy, but there are certain clinical features which is really not fitting in. So this was a patient who was referred to me as query sebaceous gland carcinoma because of this, loss of lashes, thickening of the eyelid margin. But when you look really inside, because taking a decision for an excision biopsy as a therapeutic modality in this case would be a very extensive excision. But here it is not very, very classical with the, classical feeder vessels, dilated vessels. So what I did was go in for an incision biopsy. He also had a lymph node, which probably could be a regional lymph node metastasis, or it could be any granulomatous infection. So, an incision biopsy was done, and this came out to be a necrotic granuloma, and the lymph node biopsy showed acid-fast bacillus, which finally turned out to be a tuberculosis eyelid granuloma. So there are certain dilemma in ocular adnexal tumors where you actually want to go for an incision biopsy before going in for an extensive surgery. Similar case. A child presenting with this lesion arising from the tarsal conjunctiva, you can see these micro abscesses here. There are dilated vessels. Well, it doesn't really look like a malignancy, but you never know. A rhabdomyocyte can present like this. He also had lymph node enlargement. So what I did was do an entire panel of biopsy, which includes the pathology specimen, this is a TB, gene expert for the PCR, AFB slides, blood agar, chocolate agar, and also FNAB of the lymph node. Now, this also came out to be a tuberculosis, which was proved with FNAB of the lymph node. So there are various, clinical presentation where you want to go for an extensive biopsy, and the biopsy sometimes also includes microbiological evaluation. Now, going on to the ocular surface, a 56-year-old lady, do you need a diagnostic biopsy here? Probably not, because the clinical diagnosis is right there glaring at you, lots of keratin, there is a nodular lesion arising from the limbus, extending into the conjunctiva with lots of feeder vessels, and it's straightforward. It's ocular surface squamous neoplasia. So in fact, you would go in for an excision biopsy, which is more of therapeutic as well as diagnostic. Now, would you need a diagnostic biopsy here? So this patient, in fact, had undergone an incision biopsy elsewhere, and then he was referred to me where the diagnostic of the pathologist was query possible pigmented cells, possible conjunctival melanoma. Well, what in such situation where the diagnosis is so very clear clinically would be excision biopsy. But in this case, I also included this particular area of pigmentation in a patient with xeroderma pigmentosum to rule out conjunctival melanoma. And in fact, the second lesion also came out to be conjunctival melanoma. 47-year-old gentleman, diffuse lesions in the right eye, in the left eye. So now what do we do? So the differential diagnosis in such a situation would be possible a lymphoproliferative lesion, maybe an amyloidosis. So there is actually a kind of a dilemma between a neoplasia and, a protein deficit or an inflammation. So an incision biopsy was done because this is an extensive lesion. So from the representative areas of both the eyes, from here and here, I did an incision biopsy, and it came out to be an extramarginal zone lymphoma in both of the eyes. One, very important to diagnose and differentiate. Second, in order to take a decision for treatment, whereas in lymphoproliferative lesion, often, radiotherapy is the treatment of choice. So we have to have a proof of evidence of histopathology before we send the patient to the radiotherapist for the treatment. 56-year-old lady with diffuse lesion presenting as blepharitis, seen by a comprehensive ophthalmologist, thought it's a blepharitis, but unusual blepharitis in this case. And when you see there is a diffuse lesion over here. Now, what do you do here? Would you conservatively treat the patient, or would you just take biopsy at one point, upper lid or lower lid? No. What would you do is, in a diffuse situation like this, you take a map biopsy. And this is how the map biopsy was done in this patient. In fact, I had 19 specimens, 2 into 2 millimeter specimen laid out like this, numbered, and then sent to the pathologist. In fact, this medial canthal large nodular lesion came out to be an invasive squamous cell carcinoma, and the rest was a superficial invasion. So this is regarding the map biopsy application in squamous cell carcinoma diffuse as well as in sebaceous gland carcinoma in this patient who had a recurrence. Going to part 2, the orbital lesion, neoplasm versus inflammation is when we really go inside the orbit. But there are situations where you don't want to biopsy. You decide that it could be an incision biopsy or an excision biopsy. In the child presenting with proptosis, well, no biopsy required. One thing that you really need is a CBP, complete blood profile, and a peripheral blood smear. Now, in a diffuse lesion, you decide whether most often we do an incision biopsy because it's very, very difficult to excise the entire lesion. And of course, diagnosis is so very important. It could be even inflammatory or neoplasia. And well-defined lesion, it's always excision biopsy. Computerized tomography scan of a left-sided orbital lesion, which is very diffuse. Answer is straightforward. We would go in and take an incision biopsy to rule out lymphoproliferative, neoplasia, or inflammation. A well-defined lesion in the orbit, laterally, pushing the muscle, what would we do is go in for a complete excision. Magnetic resonance imaging, where the optic nerve is thickened in a child. Well, you don't need to even go for a biopsy. It's an optic nerve glioma in a child with proptosis. So no biopsy here. So the orbital excision biopsy is done in those lesions, which is very well defined, as in this patient, the supromedial orbit, a careful dissection, and entire in toto removal of the tumor. And in toto removal is very, very important. This came out to be a solitary fibrous tumor. So never leave behind such, well-defined lesions. Not even a bit of the tumor should be left behind, because they can have bad recurrence in the orbit. And that is indeed very, very difficult to treat. In this patient who presented with all inflammatory sign, he had severe pain. During the COVID, he presented thinking that it could be even a mucormycosis. Well, it's not fitting in. So what I did was to go in for an incision biopsy. It's a diffuse lesion. Incision biopsy is pretty easy. You go through the lid crease or through the subrow approach and take a well adequate, tissue specimen and then present it. And it came out to be a natural killer T-cell lymphoma. So inflammation and neoplasia in orbit is always difficult to diagnose clinically most of the time, and even radiologically. This patient came with a nodule. In fact, clinically, I thought it could be a lymphoma. He had severe pain. All the entire inferior orbit is involved, the muscles are involved, and this came out to be an orbit IgG4 related disease. So when you go into the orbit, there are so many things apart from IHCs. Now, in order to rule out inflammation, we go ahead checking for IgG4 related disease also, which is very, very important. Now, going on to a small video showing an incision biopsy, bilateral dactylitis. I'll just show you how we go in for incision biopsy. Let's go well, small conventional diagnosis. The select incision, which is taken moving forward. The lacrimal gland is identified. Now the capsule is open. You can see it coming out. So incision biopsy, and the sample is sent for examination. Since infective etiology is also taken into consideration, this is going for gene expert to rule out TB. This is going for microbiology to rule out any other infective disease. And this large chunk is going in for pathology. So always go into the orbital part of the lacrimal gland and never to the palatal part. So this is a video of an incision biopsy that we do. Now going on to orbital incision biopsy in diffuse lesion. Well, very important to know that in this particular case, you can see there is necrotic areas in this lesion over here. So it's often very important to identify and get, the tissue out, where you can identify the neoplasia or the inflammatory cells, because sometimes if you take only one particular area and it comes out to be a necrosis, you're missing the diagnosis. So this was a case of a PMET in this patient. And what we do is, we do a superficial lesion biopsy. We go deeper. We take separate lesions as superficial, deep, and deepest in order to get the appropriate diagnosis. Sometimes it's very important to do a near total orbital excision biopsy. In this particular patient, who came with this large lesion, perforated globe. You can see how shrunken the globe is, and the entire orbit was filled with this orbit. Pretty challenging situation, pretty challenging surgery, but well, in these cases where obviously it's a malignancy, what I thought was an alveolar sarcoma or a rhabdomyosarcoma. So in these situations, a near total biopsy is so very important. And obviously, because of the curiosity, a frozen section was done for rapid diagnosis, and it came out to be a sarcoma with rhabdomyoblast. Within 30 minutes, I got the diagnosis in my hand. So now, why is this important? As in rhabdomyosarcoma and any other malignancy, what you see here is group 1, group 2, group 3, and group 4, where this actually indicates the prognosis. So complete tumor removed, it's actually a lower stage, microscopic residual group 2. But when it's a gross residual tumor, the prognosis of the treatment also worsens. So it's so very important that way. So in this 7 minutes, I hope I have not exceeded too much of a time. I would conclude decision making is usually clinical, and in Orbit, it's most favorably radiologically to decide whether you're going in for an incision or an excision biopsy. Very, very important to get adequate tissue sample, because in ocular surface lesion, if you're going for an incision biopsy, mostly you may not get a representative area, and the tissue samples may be very, very inadequate. So when you present the pathology sample to a pathologist, it's so very important to mark it, to orient it. And now we send samples for genetic testing also. So we are progressive in that way in ocular oncology. This is in in short, but two questions that I'm mostly asked in most of the, these seminars are ocular surface lesion, would imprint cytology be diagnostic? In my practice, I don't do imprint cytology. Another question in the Orbit is fine needle aspiration biopsy, is it diagnostic? I don't do fine needle aspiration biopsy in my practice. Well, we have discussants who can take this forward. Thank you so very much for your patient listening.
Thank you, Feroz, for the excellent presentation. I think we'll go to the next presentation by Dr. Santosh, who is presently the Honorary Secretary of a prestigious All India Ophthalmological Society and immediate past Editor-in-Chief of the Indian Journal of Ophthalmology and Indian Journal of Ophthalmology Case Report. Is the Director of Medical Services and Department of Ocular Oncology and Ocuplasty at Center of Site, Hyderabad, and Director National Retinoblastoma Foundation, a former head of the Department of Ophthalmic Plastic and Reconstructive and Ocular Oncology at L.V. Prasad Eye Institute. He is known for his research on retinoblastoma, and he is counted amongst the top 2% of the world researcher and amongst the top 10 Indian ophthalmologists in research, recipient of the prestigious Shanti Swarup Bhatnagar Award by the Government of India, and he is the only Indian ophthalmologist to receive the Lifetime Achievement Award by the American Academy of Ophthalmology and the Honorary Fellowship of the Royal College of Ophthalmologists, London, UK. Over to you, Santosh.
Thank you, Kasturi. Share my screen. Thank you very much for this opportunity, and congratulations, Yasi, for coming up with this wonderful idea. I'll be speaking on eyelid reconstruction and try to keep it basic in the interest of competency ophthalmologists who have a taste for oculoplasty. The goals of eyelid reconstruction are manifold. One is that we have to have ideal cosmetic and functional reconstruction of the eyelid with optimal color match, good eyelid contour and height, no ptosis or lower eyelid retraction, preservation of continuity of the eyelashes, and also provide natural, especially to the upper lid. These goals are idealistic but are definitely achievable with good planning. For the purpose of reconstruction, although we really don't have to measure every lid and follow specific reconstructive procedures, for a beginner, these may be very important to understand that there are anterior lamellar defects, there are posterior lamellar defects selectively, and there are full thickness defects. Full thickness defects can be classified as small, medium, or large, depending on the size of the eyelid that is involved. Small is less than 1/3, medium is 1/3 to 2/3, and large is more than 2/3 in an elderly individual where the lid is stretchable. But in a young individual where the lid stretch is modest, to say the least, it can be 1/4, 1/4 to half, and more than half for small, medium, and large defects. That's the classification. For anterior lamellar defects, which are in a particular location like this, especially ones which are medial, one which are extremely lateral, you may simply leave them to granulate. This is called laissez-faire technique, where you do nothing, especially small defects like this, heal beautifully well over a couple of weeks. But for defects which are large, caused by, say, a basal cell carcinoma, which would involve a large anterior lamellar defect, where you really don't have to take the full thickness of the lid, of course, that's a papilloma that comes with it, you can close it with a skin graft, or you can even take a flap from the upper lid and transpose and close it. So there are many ways of transposing flaps from the upper eyelid to the lower lid. This is a bucket handle flap where the entire upper eyelid skin has been transported to the lower eyelid. Here, the temporal aspect has been transposed. So all these procedures are very good for anterior lamellar reconstruction. We can also have a temporal rotation flap or a medial nasolabial flap as well. But for a full thickness defect, there are many procedures depending on the extent of the coloboma. For small colobomas, we can use direct closure with or without cantholysis. For medium size, we can use tensile semicircular flap. And for larger defects, we either have Cutler beard or the Hughes flap. So it all depends on the size and the location and the configuration. But what is important is to stretch the lid from both the medial as well as the lateral edge and estimate the real extent of coloboma before you decide to do canthotomy and cantholysis. For example, this patient, the stretch was possible. In fact, there was only a 3 to 4 millimeter defect. Hence, we were to close exactly like that. So canthotomy and inferior cantholysis was performed and the lid came together very easily. So canthotomy and cantholysis can be performed for about 3 to 4 millimeter gap in the lid. Whenever you do a direct closure, what is really important is that you have to have your vertical extent of the pentagon right up to the upper edge of the tarsus, and then you pentagonize it. The ratio is also important. The ratio is supposed to be 3:2, and this vertical limb of the pentagon has to go right up to the upper edge of the tarsus. Otherwise, you will leave a shallow coloboma. If you do a triangular kind of a defect, then you leave a shallow coloboma. If your pentagon is shallow, then again you would leave a shallow coloboma. So the rule is, it's called a 5-3-3-5 rule for the upper eyelid. If this is the pentagon that you have excised, this is the edge of the tarsus. Upper eyelid tarsal height is about 7, 8, 9, 10 millimeters. So you have to go 5 millimeter away from the edge of the coloboma, 5 millimeter deep into the tarsus, come back to 5 millimeter on the opposite side, and come back 5 millimeter away from the lateral edge of the coloboma, and enter again 3 millimeter, come at the depth of 3 millimeter, enter back at 3 millimeter, and come 3 millimeter away and tie the suture there. So this is a vertical mattress suture. This is for the upper eyelid. This is a simple 5-3-3-5 rule. Whereas for the lower eyelid, you can follow a 3-1-1-3 rule because the lower eyelid tarsal height is not so much as the upper eyelid. So yeah, I'll show you a video clip of direct.
Identified and incision marking is placed 4 millimeters from the tumor margin. A pentagon is marked with the vertical limbs extending through the extent of the tarsal height and the oblique limbs to join at the central apex, keeping a ratio of 3:2. 3 traction sutures are placed with 4 row silk through the center of the pentagon and on either side of it. Using a scalpel blade, and the pentagon is excised through the full thickness of the eyelid. The specimen is then sent for histopathology with the margins clearly marked for frozen section. Once the pathologist confirms negative margins, eyelid reconstruction is begun. Due to the laxity of the eyelid in this patient and relatively small size coloboma, primary eyelid closure could be done by direct suturing. Margin forming vertical mattress suture is placed with 6-0 silk using the 5-3-3-5 millimeter rule. Orbicularis closure is done with 6-0 vicryl suture. The long ends of the marginal suture are anchored to the eyelid with a single 6-0 vicryl suture. Identified and
So I typically use a two suture technique where I suture only the anterior margin after suturing the tarsus. So the suture has to pass through the tarsus. So typically you identify the meibomian gland orifices and pass your sutures right into that so that you are in the tarsus and never in the gray line. Gray line is a surgical plane and it's a weak location for a tarsus. For medium defects, we have many procedures, one of which is a tensile semicircular flap, which is a very forgiving and a useful procedure, where you create a semicircle along the pointing down for the upper eyelid and pointing up for the lower eyelid. The width of the semicircle should not be more than 2/3 of the width of the eyelid. That's about 20 millimeter is maximum. And the height of the semicircle should conform to the height of the coloboma. These are the two principal rules of a tensile semicircular flap, and the results are extremely good. I would skip the video of the tensils There are temporal advancement flap as well, where you take the help of a periosteal flap for the posterior lamina and use the skin muscle flap for the anterior lamina. For the larger defects of the upper eyelid, we have Cutler-Beard procedure, which is a very useful procedure. You can reconstruct even the entire upper eyelid coloboma with a Cutler-Beard procedure. This patient had a large sebaceous gland carcinoma, multiple recurrences, and we have lost the entire upper eyelid for this sebaceous gland carcinoma excision. Now, when we reconstruct it, we take a flap from the lower eyelid about 4 mm from the lid margin, all through the extent of the lower eyelid, and the vertical extent of the flap is also marked like that. So we are using nearly the entire extent of the lower eyelid here for reconstruction of the upper eyelid. That's the horizontal blepharotomy incision, first through the anterior lamina, then you make the vertical cuts, then you go full thickness into the eyelid, then vertical cuts again, full thickness. So this vertical flap has been mobilized under the bridge, and we now divide the flap into anterior and posterior lamina. This is very important that the flap is divided into two lamina and sutured as such, because each lamella of the lid heals separately and you have to give it independence to heal separately. Otherwise, the healing of one lamina would affect the other. Posterior lamina is closed very carefully to the corners first. Then the edge of the levator palpebrae superioris is identified, and that has to be sutured to the posterior lamina to keep the lid dynamic. And these sutures are never full thickness because the sutures will abrade on the cornea. You can see that I'm taking the levator palpebrae superioris in the upper part of the suture, and now it comes together to meet the flap from the lower eyelid. Similarly, lateral sutures are also placed. So at the end of conjunctival closure, this is how it would look. Then we close the anterior lamina, and that's how it would look. So after about 6 weeks, we divide the flap. That's an exaggerated downward convex incision that we are taking, more convex than the natural contour of the upper eyelid. And we divide in layers. That's a skin incision that is being placed. And following that layer by layer dissection, finally the lower eyelid retractor now that has come into the upper eyelid. The translucent structure that you saw just now was the conjunctiva. Then the lower eyelid bridge is freshened for suturing. That is sutured first, making sure that there is no entropion, ectropion, or lower eyelid ptosis, inverse ptosis. Then we reform the anterior edge or the lid margin using glue. You can also suture it. We remove excess tissue from the lid margin to keep it supple. Take about 6 to 8 millimeter of 4 to 6 millimeter of excess conjunctiva. You can see that excess conjunctiva that is rolled over to meet the skin, so that the lid margin is typically formed by the conjunctiva and not by any element of skin, so that they don't abrade on the cornea and cause corneal epithelial defect. So that's a Cutler-Beard procedure, and the results are very gratifying. There's an upper eyelid Cutler-Beard procedure using the lower eyelid. This was an inverse or a reverse Cutler-Beard procedure where the upper eyelid has been used to reconstruct the lower eyelid. You can see the extent of tissue that is contributed to by the upper eyelid, yet it remains normal in position and the eyelid closes as well. So there is tremendous capacity for either of the lids to contribute tissue to the other eyelid. Now about a very beautiful procedure, it's called Hughes tarsoconjunctival flap. This is a very nice procedure where the edge of the coloboma is
in the eyelid,
coloboma
4
is
mm from
tall.
the tumor margin.
This is a patient with sebaceous gland carcinoma where we are excising.
Traction sutures with 4 posterior clear margin of the conjunctiva.
So once we have done with the excision,
A superficial.
right. So
Once clear surgical
that's the
margins are
coloboma. We have
reported,
a shallow
the
coloboma.
vertical and horizontal
Of course, you
eyelid
can use
defects are
Cutler-Beard
measured.
for it. Measurement of the eyelid coloboma, vertical as well as horizontal.
A superficial horizontal incision is made along the tarsal plate,
Tarsal and
6 mm above the
tarsoconjunctival
eyelid
incision,
margin,
about 6 mm
preserving
from the upper
enough
eyelid
tarsus
margin.
to maintain the structural integrity of the
Vertical
eyelid,
cuts,
prevent
dissection
upper
of the
eyelid
flap from
entropion,
the
and
molars
preserve
and levator,
meibomian gland function.
keeping both intact in the upper eyelid. Upper limit is the superior fornix, which we generally don't want
The
to
tarsal
violate.
plate and conjunctiva are dissected free from the Mueller's muscle and levator aponeurosis just short of the superior fornix.
You can see how nicely the flap is
tarsoconjunctival
mobile
flap
once we have
is then
dissected it.
advanced into the
That is
lower
sutured to
eyelid
the
defect.
Posterior lamina of the lower
The
eyelid
tarsal plate is
coloboma.
sutured edge to
And when
edge
you do
to
this
the lower
suturing,
eyelid tarsal
you
plate
don't take it full
with
thickness
interrupted
again,
6-0
not
vicryl
to have the
sutures,
sutures abrade on the
ensuring
corner.
that the pass
If you
of the
must, you can use a
sutures
BCL
is
with a
not
tag.
full thickness.
Completing that suture, giving a height to the lower eyelid by passing lateral and medial sutures. Now we have the anterior lamina to worry about. Either you can use a small skin graft, or in elderly individual, you can do a vertical mobilization
A
of the lower
myocutaneous
eyelid.
flap from the
myocutaneous
lower
lamina.
eyelid and cheek is advanced after sufficient undermining
It
to
has to be
reconstruct
undermined
the anterior
adequately so
lamina.
that it does not pull the lower eyelid down. The position of the lid is marked, use dots for the markings, and that's
About
how
6
it is
to 8
sutured with vital sutures. This is how it
using
would
a
look
long
at the
forceps
stage
to avoid
2,
injuring the
where we would
cornea
insert a
during the
forceps
flap division.
under the flap and would simply
At the
divide it
predetermined and
using a
new
monopolar
lower eyelid
RF
margin,
electrode.
the
Again,
flap is
keeping conjunctiva
transected
slightly
using monopolar
longer
radiofrequency
so
electrode.
that we use the conjunctiva to form the lid margin. You can see that I'm making conscious efforts to harvest a longer conjunctiva.
Layer by
Is
layer
3 to 4
dissection is
millimeter
done
longer
to
than
achieve
the
complete
skin,
separation of the
and
upper
that is
and lower eyelid.
inverted to form the lid margin.
Is formed with the
Using
conjunctival
glue
planning
or
and
suture, that
skillful
is totally
outcomes
your
in the
choice.
eyelid.
This is how a Hughes tarsoconjunctival flap would look like. This is preoperative basal cell carcinoma and postoperative. And we can also do a reverse Hughes. This was a patient with Merkel cell tumor where a reverse Hughes procedure was performed. So in conclusion, I would say that eyelid reconstruction is very exciting. It may be challenging when you want to provide optimal cosmetic and functional outcome, but it is important to assess the eyelid laxity and design an appropriate reconstruction. Take care of the functional aspect by reinserting the lower lid retractors for the lower lid reconstruction, and levator aponeurosis for the upper eyelid reconstruction does provide gratifying cosmetic and functional outcome. Thank you so much.
Thank you, Dr. Santosh. Now I call upon Dr. Mohammad Shahid Alam, who had done his MBBS from Jain Medical College and then a fellowship in clinical oculoplasty from Medical Research Foundation, Shankaran Nethralaya. And presently he is a consultant at Shankaran Nethralaya, Kolkata. He is known for his academic activities, having multiple national and international publications, multiple awards, and also for his innovative work on ocular prosthesis fabrication by BioCAD and also rapid CD printing technology. And also got published in the journal Orbit. So over to you, Shahid, for discussing both the presentations.
We have
Good evening, ma'am.
Grover sir
Am I audible, ma'am?
Yeah, we can hear you. We can hear you.
Yeah, so both presentations were excellent and up to the mark and up to the point. Nicely presented. So just talking about the first presentation presented by Dr. Feroz regarding biopsies. So an important thing which I'd like to point out here is like how much how much sure we are on our clinical ground that it's a case of basal cell carcinoma or cervical gland carcinoma, but we should not proceed for a wide local excision unless we have confirmed it by incisional biopsy, because I have personally burnt my fingers in few cases where I had done a wide local excision and followed by extensive lid reconstruction, and the final diagnosis has come out to be something like as benign, especially in case of sebaceous gland carcinoma. Sometimes it will come as sebaceous adenoma or a case of sebaceoma. So it's always advisable to first do an incisional biopsy, confirm the diagnosis, and then you go ahead with your final plan of management. I mean, if it's a very small lesion, so what you can do, you can excise the whole thing without any margin in that setting, get the diagnosis, and if the diagnosis comes out to be malignancy, SGC or BCC, then in the second sitting, you can go ahead and excise the margins and do a reconstruction. Then regarding cases where you suspect that it can be a tuberculosis or can be a malignancy, you have a dilemma. So in those cases, I just like to say that if the sample is small, and then you don't need to send it to separately, like for GMS or ZN staining. What you can do, you can just straight away send to histopathology. Histopathologist will, if the histopathologist has a doubt of tuberculosis, if they see caseating necrosis, then a PCR can be directly done over that same H&E stained specimen. A PCR can be done, and you can get the diagnosis of tuberculosis. The second next thing is map biopsy. So map biopsy, yeah, it's like whenever you suspect a case of sebaceous gland carcinoma with vegetoid spread, especially cases presenting with blepharitis, a map biopsy is indicated as pointed out by Feroz. The only problem is like cases where you get positivity only for few sides. Like recently I had a case where only the upper lid was positive, but whole of the other surfaces were negative. So then in those cases you have really a dilemma like what to do, because you need to excise whole of the posterior lamella of the upper lid and then reconstructing it is a real challenge. Regarding peripheral blood smear in leukemia, just a word of caution that there can be cases of aleukemic leukemia where peripheral blood smear can be negative. So in those cases, a biopsy is indicated, and a bone marrow biopsy is also done. So that was about the Feroz presentation. Then coming to Sir's presentation, Santosh Honawar sir, presentation was excellent. And if I am like I cannot add anything to that whatever Sir has presented. Just very few points. Like for lower lid defects, I personally hesitate repairing large lower lid defects. I just leave it for healing by secondary intention or by laissez-faire. And all these lower lid lesions, they heal very beautifully. And there's hardly any lag of thalamus. So you can rely on laissez-faire for lower lid defects. Tensile flap is a workhorse flap for me for almost all of the reconstruction. And recently I have done a modification in tensile flap where even defects greater than more than 2/3 of size of the lid can be repaired. So I'll be shortly sending that for publication in IGO, that modification. And as Sir rightly pointed out regarding cutler beard repair, a mistake that many of us do is not dividing the anterior and posterior lamella. So that is very important whenever we are reconstructing the lid using the cutler beard. It's very important to divide the anterior and posterior lamella and then suture them separately. And when you divide, you make sure that the upper lid margin is lined by a mucosa. Suturing of the lower lid also is very important when after division of the flap, which otherwise it will lead to entropion and ectropions. And I personally, just as a word of caution, I avoid lid sharing as much as possible in cases of malignancy. If I'm doing a lid reconstruction in the case of malignancy, I'll try my best not to go for a lid sharing procedure, just in case that there is some residual tumor there and it gets spread to the other side. So yeah, if I don't have any option, you have to go for a lid sharing procedure, but I try to avoid that. Yeah, so that was all from my side.
Thank you, Dr. Mohammed. Thank you so much for the beautiful discussion. And we are so happy to have Professor Padma Shri, Dr. A.K. Grover, sir, a mentor for all of us. So, Grover, sir, please, do you want to add some points or would you like to discuss regarding both the presentation, one on biopsy or the adnexia and the lid, and second, the beautiful presentation by Dr. Santosh on the lid reconstruction. Would you like to share your experience, sir?
Excellent presentations. And as usual, covered beautifully and exhaustively. Santosh did a wonderful job, beautiful videos, always enjoy them, but would just like to thank Dr. Prashant Bavankule for this series of excellent AIUS ARC webinars, as well as those PG teaching programs that he's doing, and would like to compliment you for this beautifully organized teaching session for the oculoplastics. So thank you all, and wonderful programs. I'll be going for the eye focus talk in a short while. So see you later, and all the best for the program.
Thank you, sir. Thank you for joining us, sir. So I think in the interest of time, may I request Dr. Shubhra to call upon the next speakers?
Yes, a warm welcome, and thank you so much for this opportunity, Dr. Kasuri and Dr. Prashant. I take this pleasure to invite Dr. Preeti and Dr. Mukesh for the next session, and the discussant will be Dr. Roshmi Gupta. So Preeti is a senior ocuplastic surgeon from Chennai, and she's trained in Shankar Nethralaya. Currently is the director of the DRR Eye Center and also the head of Ocuplasties for Agarwal Eye Hospitals. She's trained at UCLA and has exclusive work in trauma and also in faculty of AOMCF. And she's also a prominent FRCS examiner. So Preeti, over to you for your talk on evaluation on entropion and ectropion, please.
Good evening to all of you, and thank you very much for this wonderful introduction, Shubhra. And thanks to Dr. Prashad and Dr. Kasturi for having me over. This is a wonderful evening today. It's nice to go back to basics, and my job is easy today, and I will be discussing only the evaluation of ectropion and entropion. So we know that entropion is inward turning of the lid margin. And when you see a patient with entropion, you want to know whether it is congenital or acquired, because in congenital cases, more often than not, it is not a true entropion. Most of the babies that we see have epiblepharon, that is, their lid margin is in normal position, but there is an extra fold of skin and muscle which is overhanging over the lid margin and giving it an appearance of entropion. Now, luckily, this epiblepharon is not very serious, because most of the time these lashes are very, very thin lashes. They do not cause much of conjunctival congestion. Most of these babies have watering, and you can just get away with lubricants. As the baby grows and the midface grows, this fold of skin gets corrected and the epiblepharon gets corrected. When you have a little severer form of epiblepharon, you can also use fillers for the anterior lamella, stretch the anterior lamella. That corrects the epiblepharon temporarily, and this buys us time, and as the baby grows, the epiblepharon gets corrected, and you can avoid a scar on the face, which is an unsightly scar which is given by the Holt's procedure. Now, once you know that it is not congenital, it is not epiblepharon, now acquired entropions can be either involutional, cicatricial, or spastic. Now, straight away, you can rule out a spastic entropion by putting a paracaine drop on the ocular surface. That will correct any kind of ocular irritation that is causing the spasm. And if that gets corrected with a drop, you know it is spastic. And what you need to do is treat the cause of ocular irritation and not the eyelid. So the job becomes simple. The ocular irritation has to be corrected, and that corrects the entropion. Now we are left with involutional and cicatricial entropion to deal with. Involutional entropion is because of laxity of the tissues, because of aging. So whenever there is laxity of the eyelid can roll inwards or outwards. You can get an entropion or an ectropion. The cause remains the same, that is laxity due to aging. And when there is cicatricial entropion, now since the lid margin is turning inwards, you know the cause has to be on the conjunctival side. The conjunctiva has to be scarred for it to pull the eyelid margin inwards. So you look for causes that cause a scarring on the conjunctiva, like chemical injury or trachoma or Stevens-Johnson's. Also, very common cause of this is cicatricial entropion is surgery. Now, most often we are doing orbital surgeries through conjunctival approach. And if the layers are not respected, that can cause a scarring on the conjunctival side and cause an entropion. This is very commonly seen after trauma repair, because during trauma surgeries, you are doing a very large dissection, causing a lot of fibrosis, and that causes a cicatricial entropion, which we very commonly see after midface reconstructions and orbital reconstructions. Also ask for history of trauma, because the trauma per se can affect the conjunctiva and cause a scarring. Now coming to senile entropions are more commonly seen in lower eyelid, because the upper eyelid tarsus is more stable. It is about 10 millimeter in height. And therefore, a loose laxity of the tissues do not very often cause an upper lid entropion compared to a lower lid entropion. So when we ask history of the patient, you must ask the history in such a way that you know the cause, and so that you can treat that cause and correct the entropion. So in addition to the usual history of onset, duration, progress, unilateral, bilateral, or which eyelid is affected, you need to ask history for any chemical injury or any trachoma or drug reactions to rule out Stevens-Johnson syndrome, lid surgery, as I said, especially orbital surgery, and trauma. Also, an important history here is patching for long duration. If the patient is having had to be patched for long, especially because of corneal problems, that triggers a spastic entropion. Now, this is a patient who has had an orbital trauma and he's had a cicatricial entropion because of conjunctival scarring. So symptoms, usually these patients present with symptoms of ocular irritation like burning sensation, irritation, redness, watering, lid swelling. Also, they can have facial spasms, which can cause spastic entropion. or reduced vision because of corneal aberrations and corneal pathology. When we examine these patients, you must look for hemifacial spasm, blepharospasm, because these can cause spastic entropion. And sunken eyes are more commonly prone to entropion. So if you see these very old patients, they can have sunken eye, which causes an entropion. Also look for enophthalmos, microphthalmos, phthisis bulbi, which affects the dynamics between the eyelid and the ocular surface. Now, when we examine the patient for laxity, we need to know which part of the eyelid is lax. Is it the medial, lateral, or the entire eyelid is lax, like the horizontal lid laxity, so that you can take that particular part of the eyelid and correct the entropion. So when you're checking, now I will show you a video as to how to examine for these laxity. Also, you must look for overriding of the preseptal over the tarsal orbicularis. Look for excursion of the lower eyelid in down gaze. So usually when the patient looks down, the eyelid should move by a few millimeters downwards. When the lower lid retractors are dehisced or they are disinserted from the tarsus, then the eyelid will not move along with the eyeball. So when the patient is looking down, the eyelid remains in its normal, in the same position, does not move down along with the. So in these cases, you know that if you do a Jones procedure, it will help because you're going to reattach the levator retractor and the lower lid retractors to the tarsus. Also, when you see fat prolapse in the lower eyelid, you know that the orbital septum is now lax. So this is how you examine. This is basics for any undergraduate or postgraduate students. It will be useful. You can see there is a clear-cut override, the bunching of the orbicularis. There is laxity of the lower eyelid. So this is the lid distraction test. You are able to distract the lower eyelid by more than 8 millimeters. And the eyelid is not snapping back to the normal position without a blink. You can see it is not going back and opposing to the globe without a blink. So that is a positive snapback test. So the snapback test and the lid dehiscence test tells you that there is lid laxity. Now I'm checking for MCT laxity. You can see the punctum is going beyond the limbus. So if you are able to distract the punctum by more than 1 or 2 millimeters, there is an MCT laxity. If the punctum comes up to the limbus, it is mild. And if it comes up to the pupil, it is a severe MCT laxity. Similarly, you will check for lateral canthal tendon laxity. If you're able to distract it by more than 2 millimeters, there is lateral canthal tendon laxity. So this is the lid distraction test. You're able to distract more than 8 millimeters, means there is horizontal lid laxity, and you're going to do either a wedge resection or a lateral tarsal strip. This is a typical roll of orbicularis that you can see in a overriding of a preseptal over pretarsus orbicularis. So in this case, you know, when there is an override, you want to create a scar tissue between the two so that the override is prevented. So that in these cases, a Weiss procedure will be useful. Create a scar between the two parts of the orbicularis. Now, also when you're evaluating for entropion, you look for orbicularis function, whether the orbicularis tone is adequate or not, because a certain amount of tone of orbicularis is needed to keep the eyelid in its normal position. So ask the patient to close the eye tight and see and look for the tone of the orbicularis. Also look for any masses on the conjunctival side. Look for trichiasis or metaplastic lashes, which tells you that there can be some scarring going on, and that can be associated with cicatrician entropion. Now also examine the conjunctiva. In cases of entropion, you need to see if there is any scarring or fornacial shortening, if there is any congestion, symblepharon, thickened tarsal plate, which you see in trachoma patients, or if there is a white line that you see on the conjunctival aspect. That is the detached edge of the lower lid retractor. And once you reattach it, the entropion gets corrected in these cases. So you will see a white line, which is the edge of the dehisced lower lid. Also, of course, examine the cornea, look for any aberrations, epithelial defects, and corneal sensation. Now, till the patient is referred to the ocuplasty surgeon, this is what you can do as general ophthalmologist in your clinic. That is, you can tape the eyelid. Okay, so you place a tape from the margin and pull the eyelid and keep it to the cheek skin. So that relieves the patient of the entropion. Also, the ocular surface irritation gets relieved till a final.
Entropion surgeries, ptosis surgeries.
Another
कौन सा जनरल ऑप्थेल्मोलॉजी सेंटर?
Can I ask everybody to mute themselves, please? Now, coming to ectropion, which is outturning of the eyelid margin. Again, we have congenital and acquired causes. Congenital can be because of shortage of skin. Congenitally itself, the lid can be short. There can be shortage of the anterior lamina, or there can be congenital skin abnormalities like Ptosis, which causes shortage of. And acquired causes can be involutional. Again, as I told you, with aging, when there is laxity, the eyelid can turn inwards or outwards. Another important cause is mechanical. You can have a tumor on the eyelid that causes an ectropion. There can be cicatricial causes like burns or any scar tissue on the outer side. Especially we see it post blepharoplasty. Whenever lower lid blepharoplasty is done through the skin approach, you can get a cicatrix in the anterior lamella, which causes an ectropion. And in facial palsy cases, you see paralytic ectropion more often on the medial side, causing a punctal eversion. Now, again, you need to check for laxity in cases of involutional ectropions, which I have already discussed before, and look for any signs of trauma, burns, or surgery like blepharoplasty, tumor excision, and dermatological disease. So here I like to highlight that very often in the clinics, we see patients with ectropion, which is caused by anti-glaucoma medication. If you see if the patient is on brimonidine or some such drugs which causes contact dermatitis on the lower eyelid skin, and that is a very, very common cause of ectropion in our clinics. And in these patients, what I tell them is to stop all anti-glaucoma medications and to start the patient on Diamox, give the patient some mild steroids, wait for some time for the entire thing to heal, and then change the anti-glaucoma medications. Now, these are some of the cases, like this is a congenital ichthyosis wherein there is scarring of the anterior lamella and causing ectropion. Here there is a post-trauma scarring. You can see the upper lid, there is an ectropion. Another patient, post-trauma scarring causing lower lid ectropion. And this is a patient who has had a large resection of a tumor by an oncologist, and that has caused a shortage of the anterior lamella and ectropion. Of course, facial palsy is a very, very common cause of ectropion that we see. So when we examine these patients, again, in addition to the regular history, you need to ask the patient, since the eyelid is turned outwards, you need to ask the patient if there is any exposure of eyes during sleep, if there is any lid mass, watering from the eye, redness and weakness of that half of the face, which will tell you that he has facial palsy. Also, since the punctum is everted, sometimes that punctum can stenose. So look for stenosis of the punctum, look for any, how well the punctum is opposed to the globe, the contact of the punctum to the ocular surface. Now, in these cases, if there is severe ectropion and if the conjunctiva is exposed, the exposure itself can cause keratinization and congestion of the conjunctiva. And that you need to look for in these patients. And of course, skin scarring, erythema, and corneal exposure. Now, one useful test for us to know if there is skin shortage is to recruit some skin from the cheek. Okay, so you push the cheek skin up, and if that corrects the ectropion, you know that there is shortage of the anterior lamella. Also, when the ectropion worsens with mouth opening, you know that there is shortage of the anterior lamella, because that will pull the skin down and worsen the ectropion. So ectropion can be graded as mild, moderate, severe, depending on, now mild means there will be mild turning of the eyelid. You will see the posterior margin of the eyelid. And grade 2 is when the palpebral conjunctiva is exposed, and grade 3 is when the corneal conjunctiva is exposed. So this is an early mechanical ectropion because of basal cell carcinoma. You can just about see the posterior lid margin. You can see on the left side, you can't see any lid margin, but on the right side, you can see the lid margin. And the severe one is this, where you can even see the corneal conjunctiva. So that's all in the evaluation of ectropion and entropion. I think the surgical part, Dr. Mukesh is going to cover the correction of the lid margin malpositions. Thank you very much for this wonderful opportunity.
Thank you, Preeti, for a very concise synopsis on the evaluation. I think it's going to be useful for all the budding oculoplastic surgeons. Now I have a pleasure to invite Dr. Mukesh Sharma, a senior oculoplastic surgeon from Jaipur, trained at AIIMS, and presently Director of Center for Sight Jaipur. He's also the past Secretary of OPAI. Over to you, Dr. Mukesh, for your tips on the surgery for Entropion and ectropion. Thank you.
Thank you, Dr. Shubhra. My screen is visible? Yeah, it is.
Yeah.
All right. So at the outset, I compliment Dr. Bhavan, Dr. Kasturi for designing this wonderful program and also for having me there. So without wasting any more time, I shall be discussing some of the common surgeries for entropion and ectropion. Dr. Preeti has discussed all of them and she has made my job really very simple. I shall be discussing only few of the representative surgeries, and I believe that this program is for comprehensive ophthalmologists. So my aim is to sensitize them with some of the common surgeries so the same can be replicated by general ophthalmologists, and these surgeries are quite simple. So I think all of us, all of the general ophthalmologists, they can do it. So as Dr. Preeti has just now told, and the involutional ectropion and entropion, they both are part of same process, same disease process. If there is laxity of both anterior lamina and posterior lamina, we have ectropion. If there is laxity of posterior lamina but anterior lamina is having normal tone, then we have entropion. Horizontal laxity and all these things have already been discussed by Dr. Preeti. So what are the options for involutional entropion? There are some temporary everting sutures. There can be V's procedure. There can be Q-cut procedures, Wheeler's procedures. Then there can be lateral tarsus strip along with everting sutures if it is required. And then a Jones procedure, which is a good procedure. It's a permanent procedure and it can be done for recurrences. So if you want to pick up one or two procedures, then I think lateral tarsus strip and Jones procedures, these two are the procedures which all ophthalmologists should know. If there is horizontal tissue laxity, then LTS or lateral tarsus strip is the procedure of choice. If there is no gross horizontal laxity, but there is entropion, and I'm talking about involutional entropion, then I think Jones procedure is the procedure of choice. So I shall be discussing both of these procedures in some detail and showing their videos. So I'll go to Jones procedure. In Jones procedure, what is done is that we shorten and plicate the lower lid retractors. And by doing that, we create a barrier for the upward movement of preseptal orbicularis. And this can be done as a primary procedure and also for recurrences. If there is gross horizontal laxity, then obviously we do go for LTS. So this is a diagrammatic representation. And you can see this plicating suture is being is passed in the lower lid retractor. So how this surgery is done? We just mark around 4 to 5 millimeter area, incise the skin either by the help of knife or by the radio frequency cautery. I'm sorry for this. Then orbicularis. So skin orbicularis, then you have got orbital septum, and underneath the septum there is fat. So this shining thing is orbital septum. So remember this: skin orbicularis, then orbital septum, and underneath the septum is fat, and below the fat you have got capsulopalpable fascia, which is the analog of levator in lower lid. So you can see this fat is getting visible once we have cut the orbital septum. So this is the orbital septum, which I am holding here. Orbital septum, fat. Underneath this is capsulopalpable fascia. We shall be plicating this. And this is skin, orbicularis, septum, fat. I'm just going step by step just for the use of general ophthalmologists. These are not for the learned oculoplastic surgeons. I know I'm going very basic. Then what is done is this capsulopalpable fascia or the lower lid retracted. It is plicated. Suture is passed from orbicularis, one end of capsulopalpable fascia going through the orbicularis, tarsus, and coming out. Tarsus, then orbicularis, then it is coming out. So you are just plicating the intervening part of capsulopalpable fascia. And excess skin one can resect out, and one can correct easily any amount of entropion by this particular procedure. Tarsus wedge resection. This procedure I acknowledge. This is by Dr. Santosh on our this video. So again, a very simple procedure. If there is trichiatic lashes, you do electrolysis of those lashes also.
When properly done, the lash using monopolar
Then
radiofrequency electrode.
again, you make an skin incision either by knife or by radiofrequency cautery. This is made at around 5 millimeter or so from the lash margin. You reach, dissect and reach up to the tarsus plate, surface of tarsus plate. And if you are having a radiofrequency cautery, then you can very nicely resect out the wedge. Without this, it is really problematic. One can do it with the shave off with the help of knife also, but this is not so meticulously done with knife. One of the rarer indications of uses of RF cautery. So once you have made the wedge, you just pass a vicryl suture through the upper end, so the this will be everted. This tarsus plate would be everted on the apex of wedge, and the entropion would be corrected. So once you have done this suturing, then do orbicularis and the skin suturing. Now, briefly, I will be discussing ectropion part and also the lateral tarsus strip. This, I think, is already been covered beautifully by Dr. Preeti. These are some of the treatment procedures for ectropion. For mild cases, one can do electrocautery. Also, inverting suture may be passed. In this, suture is passed from the lower end of tarsus, and then we come out close to the periosteum, near orbital rim, and tie. Again, it's not permanent procedure. Generally, it is done in combination with other procedures like lateral tarsus strip. So I'll not go describe all the procedures. I'll be describing this lateral tarsus strip. It's a very gratifying procedure. This can be done both for entropion as well as ectropion. Wherever there is horizontal tissue laxity, one can do and one should do lateral tarsus strip. For entropion, you can combine this with everting suture. For ectropion, you can combine LTS with inverting sutures. So how it is done? You do canthotomy and cantholysis just to make lower lid mobile, lower lid or upper lid. If excess lid skin is there, then it is draped over the lateral canthus and cut. Approximately 5 to 7 millimeter of lateral part of lower lid is split at gray line. Conjunctiva is shaved off. Then we secure the lateral strip of tarsus to the periosteum by help of a single horizontal mattress suture at or above the level of inferior pupil. So this is very important to secure it above. So this is how lateral canthotomy and cantholysis is performed. Then skin is shaved off. We are just removing the anterior lamina, preparing a lateral tarsus strip. Then the conjunctiva is also cut. And epithelial cells from the top also is resected so that there is no epithelial invasion, because this part of strip would be sutured inside and this will be sutured to the periosteum. So now a horizontal mattress suture is passed. First we dissect out and reach up to the periosteum. And you pass this suture not at the lateral canthal tendon insertion, but slightly above, because you want to pull it up so that there is some amount of basically scope for future downward sag of lower lid. So horizontal mattress suture is passed and then it is passed into the periosteum. So your lax lid has been tightened up, and this will correct horizontal laxity of both entropion and ectropion. Here we have done Kuntz-Zaimowski along with the lateral tarsus strip for this ectropion, and this has got corrected. Similarly, in this particular patient also LTS is done along with Kuntz-Zaimowski procedure. This is a common paralytic ectropion photograph, facial, long-standing facial palsy. So what can be done is facial sling. A silicone rod can be passed or a non-absorbable suture can be passed all around the palpable fissure, around 3 millimeter away from lash margin. I am exploring this with the help of facial artery strip. Soon we will be able to tell you more about role of facial artery in this particular condition. So here we have passed a silicone rod all around, and this paralytic ectropion has got corrected. But with passage of time, you again get some amount of droop. These are cases of cicatricial ectropion. In early cases, one can do jetplasty. In severe cases, we need to do a skin graft. So here a jetplasty is done. The vertical limb of jet is placed over the scar line, and these triangles, they should not be very high. The angle between these triangles should not be more than 60 degrees or so, otherwise there will be problem in relocating and transposing these two flaps. So this is how this particular surgery is done and post-operative picture. So you can see this cicatricial ectropion has been corrected. Mechanical ectropion, we all know ectropion due to any cause, tumor, etc., lid get everted, and you treat the cause, that will be corrected. So to conclude, each patient of entropion and ectropion need to be assessed for type and severity. These are very simple surgical procedures, and I believe any general ophthalmologist can do these procedures. I believe most of the general ophthalmologists, they have done these procedures initially in their early period. Now we are with time shying away from doing any specialized procedure, but I believe more and more people should do simple entropion and ectropion correction. Thank you. Thank you for your patience, Yanni.
Thank you, Dr. Mukesh, for tips and tricks on entropion, ectropion surgery. Now invite Dr. Roshmi Gupta. She's the discussant for the session. Roshmi, welcome to the session. And you are a senior oculoplastic surgeon presently in Bangalore. You have been a past HOD of Narayan Netralia for the Ocuplastic, and trained at LV Prasad and USA. Beautiful surgeon, beautiful human being. We need tips and tricks on the entropion, ectropion topic which was discussed. Thank you, Roshmi.
Thank you, Shubhra. I'm very grateful to Dr. Prashant and Dr. Kasturi. I love being part of this session. About the previous speakers, they were both such wonderful speakers. Dr. Preeti did a systematic description of how to evaluate entropion, and Dr. Mukesh described in detail with wonderful videos and demonstrated exactly how the best procedures for correction of entropion and ectropion are. So both of them highlighted the need to correlate findings and the decision of what surgery needs to be done. For example, you would have noticed talking about the role of orbicularis. And so therefore the need to create a scarring to make sure that the preseptal orbicularis does not roll over the pretarsal, or detecting the lid laxity and making sure that that is corrected. So evaluation is not just an academic exercise, it guides how we treat it. And the other highlight we got out of these talks is there are also unusual causes which are not so well known when we are students, but we discover them as we go into practice, such as, patching can cause spastic entropion, or anti-glaucoma medications can often end up causing cicatricial ectropion. In this regard, although it's rare, upper lid senile entropion is also known. We do see it. If Dr. Mukesh or Dr. Preeti would say very briefly in a couple of sentences how they would want to tackle an upper lid senile entropion.
Yeah. I believe wedge resection is the procedure which can be done for upper lid senile entropion also. And yes, we do see senile entropion of upper lid. Here, everything is thinned out, tarsus plate is thinned out, muscles are thinned out. So in wedge resection, you need to really excise a wedge which is broad, basically, apex narrow and broad wedge, so that a thinned out tarsus plate can give you optimal result. So it is a condition which is not so like well depicted in textbooks, but we are seeing these cases.
Dr. Preeti, how about you? Is that the same way you would do it?
I would actually prefer a lateral tarsal strip, even for the senile upper lid entropions, the upper strip from the upper eyelid. But what I want to highlight is very often these cases of floppy eyelid syndrome. And that can be missed in many cases. I have seen they have been referred to me for senile entropion correction, but they have floppy eyelids. So I think that should not be missed in these patients. And I am very conservative on excising the entire full thickness skin like a wedge resection to a lateral tarsal. A medial component, like a medial canthulin plication or something like that.
Thank you, both of you. I agree that there is very often upper lid laxity as well. Even though we test mostly for lower lid laxity, upper lid laxity is also an entity that is there. And often when we correct the upper lid condition, it makes sense to do a lateral canthoplasty from the upper lid. And with that, I come to the end of this discussion. You were both wonderful teachers. It was a pleasure to be part of this.
Thank you.
And you were a very concise and precise discussant, Roshni. Thank you. I think all three of you did a wonderful job. Next, move on to the next session, which is on ptosis. I think that's one of another common surgeries and conditions which we see as general surgeons, ophthalmologists, and general oculoplastic surgeons. So it's my pleasure to invite Dr. Sendil Nathan, Dr. Kasturi Bhattacharjee, and Dr. Akshay Nair. I'll be introducing
Nirmala Madam to just tell from her experience. She has done lots of entropion and ectropion when we were doing her fellowship under her. Madam, yes. Can you hear us, Madam? Nirmala Madam? Madam, are you there? Bitheria, sir, would you like to share your experience, sir?
About entropion and ectropion.
Yes.
You see, many a times when the patient is lying down and when you are doing the senile entropion, say Jones operation, the excision of the skin muscle lamina is little tricky, because if you excise too much of the skin muscle lamina, you may not understand it when the patient is lying down. But when the patient sits up, you will see that you exercise more and you have caused ectropion instead of treating the senile entropion. I think we have to be very careful in excision of the skin muscle lamina. It should not be too much of the skin muscle lamina which you should excise. Similarly, when we do the ectropion surgery like Kunz-Zimanowski, etc., we find that on the table we have corrected the ectropion, but once the patient sits up, you find that ectropion, because of the gravity, which you did not understand when the patient was lying down. So I think then as far as the entropion is concerned, many a times there is entropion, but there's more of trichiasis. Because I was in Muscat for many years, and there the trachoma was rampant. And in trachoma, there was a cicatricial entropion, as well as there was too much of trichiasis. So we have to differentiate between the trichiasis part and the entropion part. And for too much of trichiasis, you have to do what is called as an anterior laminar reposition, which is very important. That means you bisect at the gray line, and then you pull the anterior lamina more posteriorly and make the raw area there, which heals up later on in a week's time. So I think these are some, and we have to really balance the anterior and the posterior lamina, because whole understanding and all these procedures are devised on assessment of the anterior lamina and posterior lamina. If we are able to balance them, there is no need of going into all this bookish knowledge. You can decide on the table what is happening to the anterior lamina, what is happening to the posterior lamina, what is happening to the thickness of the tarsal plate. If it is thick, you have to do wedge resection. If it is thin, you have to do eversion of the tarsal plate. All those procedures are there, so it all depends upon case to case. There are no generalized rules, but what I have understood of these procedures is that patient must be assessed. After getting up on the table, you ask the patient to just get up so that you understand what you have done about the excision of the skin muscle lamina in particular. Thank you very much.
Thank you so much, madam. We have seen so many cases of ectropion, like all the graphs. Would you like to share your experience?
Can I, are you able to hear me?
Yes, ma'am.
Now, the one point which I noted, which Preeti had made, was it is going to be very useful for the ophthalmologists, general ophthalmologists. That is, when a patient comes with an entropion, immediately they want some relief. So the simplest thing to do is put in a tape to pull out the anterior lamina down. I think Preeti had shown the pictures very nicely, and it is very impressive. I think that is something which should be used. The other thing is in ectropion, which occurs many times because of laxity as well as aging process also. The main complaint most of the patients complain is watering. What do we do for that? You can't immediately take the patient to the theater and start operating on him, but you have to do something else. What can you do? This is what you have to explain. You have to counsel the patient. You have to tell them that if they are going to wipe their tears, which is coming out onto the cheek, they should use something which should be very clean, like either a tissue paper, facial tissue paper, or a clean kerchief. If they start using all sorts of towels, which I saw one of the patients did today, they do tend to get some infection. So it is better that they are taught and they are told what is to be done when there is so much activity. The various techniques which have been mentioned have been very correct. Now, one thing is, especially for the upper eyelid, if there is entropion because of cicatricial reason, after I think trachoma, which we get very many times, one has to replace amount posterior lamina with or tarsoconjunctival. For the upper eyelid, unfortunately, because the growth graft. but it can be used for the lower eyelid. So for the upper eyelid, the correct this Pardon? Anyway, I don't think I want to go into details about the various techniques because that would be wasting time. The idea is the ophthalmologist should be able to identify the condition and refer it to the specialist, that is the oculoplastic surgeon. I think that this is a subject which is becoming quite popular amongst youngsters, and I'm sure every center will have.
Thank you.
Thank you, ma'am. I request Dr. Nayan Gupta to mute himself because there is a lot of audio disturbance from his end, and that's interrupting our own discussions. Dr. Nayan, please request him.
Okay, Shubhra, please go ahead.
Sunilji, can you mute Dr. Nayan Gupta? Hello? Technical team? Hello? Hello? Let me call him. Kasturi ma'am, you can well go ahead. I will call the technical team.
Yeah, thank you, ma'am, for your tips as always. Let's move on to the next session, which is on Ptosis. And I'd like to invite Dr. Sendil Nathan, Dr. Kasturi Bhattacharjee, and Dr. Akshay Nair. Dr. Sendil will be talking on the evaluation of Ptosis, and Dr. Kasturi will be taking us through the surgical procedures, and Akshay Nair is the discussant. Dr. Sendil is a senior oculoplastic surgeon from Chennai and has been trained in Shankar Netralan as well as Orbital. His area of interest is trauma and reconstruction mainly, apart from the other areas. So, Dr. Sendil, over to you for your presentation.
Thank you, madam. At the outset, I'd like to thank Dr. Prashant and Dr. Kasturi and the whole ARC team for giving me opportunity. I'm going to share my screen now. Can you see my screen, madam?
Yes, yes.
Yeah, okay. So today I'm going to talk about Ptosis evaluation. It's a very common condition which all of us see in our OP. And just to give you an example, this patient was referred long back with a complaint of Ptosis, sudden onset Ptosis in the left eye. You can see he's a young patient. But on closer examination, you can see he's got multiple cafe spots. And when we did a CT scan, you can see he's got bilateral acoustic schwannomas and meningiomas as well. And it turned out to be type 2 neurofibromatosis with multiple CNS issues. So this again goes to show why each case of Ptosis needs to be approached very carefully with a systematic examination. That's very important. Why is it very important? We need to determine the etiology. What are the cause for the Ptosis? Is it a myogenic, neurogenic, aponeurotic, mechanical, or pseudotosis? We need to see why the Ptosis come. And you need to plan treatment. What procedure you're going to offer to the patient, LPS resection, a frontalis sling, or a fusnal servet, whatever you want to do. So only if you assess these patients in a systematic way, you will know how to manage this patient. Coming to the Ptosis workup, basically you can divide it into four main parts. One is history taking. Second is external examination. Third is actual Ptosis evaluation. And the fourth is the other ancillary tests which you'll be doing. So when you see a patient with Ptosis, don't jump in and straight away examine the eye. You go in a systematic way. Take history, face examination, Ptosis, and then the other tests. Coming to the history, you want to know what is the age of onset. Was it at birth, acquired? Is it long-standing or short duration? Any other history of trauma, inflammatory eye disease, and any history of variability, associated diplopia, and systemic symptoms as well. And past medical and surgical history is very, very important. And family history also is important. So you can see this very young patient has Ptosis from birth, you know it's congenital. Whereas in these patients, you can see elderly patients sudden onset Ptosis for the last few months or few years, had history of surgeries done, cataract surgery, or you can see the other patient who's got an Entropion. And then, you know, this is a case of acquired Ptosis. And this child came with history of sudden onset Ptosis following injury with a door handle. You can see he's got Ptosis in the right eye, clear-cut history of, history of trauma. Similar patient with sudden onset Ptosis following trauma. And these patients, if you wait, they usually spontaneously recover. So again, history of trauma is very important. And these patients, again, the patient on the right side, you can say had a history of evisceration done, had severe inflammation and associated ptosis, whereas the child on the left has sudden onset swelling of the eye with a droopy lid, and on biopsy, she had a rhabdomyosarcoma. So all case of ptosis, you have to take a proper history. Again, history of variability is very important. Is the ptosis the same throughout the day, or is it progressively worse with exertion? That could be an indicator of myasthenia. Family history, again, you can see the patient on the right and her mother on the left, both have similar ptosis. And again, family history is known to, ptosis is known to run the families as well. Coming to the face, you examine the face to see if there are any signs of any syndromes, chin elevation, examine the lids carefully, and always palpate the face and the forehead to see if they've got any previous surgeries. And this is a classical case of oculopharyngeal dystrophy. You can see the dystrophic face, you can see the bilateral ptosis. And this again is a patient with what's called a CPEO, chronic progressive external ophthalmoplegia, where there's no elevation along with ptosis. You can see the wasted muscles of the face as well. And chin elevation, again, is very important. Why chin elevation is important, especially in a pediatric patient. You can see in the patient on the right side, there's no chin elevation at all. Whereas in the left, you can see a bilateral ptosis, the child elevating the chin. So when the child elevates the chin, that means he's making an attempt to see through the ptotic lid. And so the risk of amblyopia is slightly lesser. In contrast to a child who has no chin elevation at all, that means the child is given up on the ptotic lid and using the other normal eye. So the risk of amblyopia is very great, and you need to operate as early as possible to help the child recover vision. Again, mechanical ptosis, patient was referred as a case of hemangioma. You can see on systemic examination, multiple capsular spots. Actually, it was a S-shaped lid of a neurofibromatosis. So all case of ptosis, see the globe as well. You can see this patient has got a microphthalmic eye, and actually he's got a pseudoptosis. And this patient, again, patient with anophthalmia presenting with ptosis. So always do a proper face examination. And coming to the ptosis evaluation as such, I usually divide into 12 steps. And this is how you go about it. You first measure the vertical palpebral height, the marginal reflect distance, the amount of ptosis, LPS action, lid crease height, C for phenomena, Marcus Gunn phenomena, and the Bell's phenomena, and the EOM, the pupil, and do the cover test, check the cornea and the tear film height. And coming to the vertical palpebral height, as the name denotes, it's distance between the upper lid and the lower lid when the patient looks straight. And usually the males it's 7 to 10 and females it's 8 to 12, and check it with the patient looking straight ahead. And the difference between the vertical palpebral height in the two eyes denotes the amount of ptosis. Coming to the MRD, this is the most important documentation in the case with the ptosis, the marginal reflex distance. So you have what is called as the MRD1. You shine a light onto the eye of the patient, and the distance between the light reflex and the upper eyelid margin is the MRD1, with the patient looking straight. Normally, it's around 4 millimeters, 4 to 4.5 millimeters. And MRD2 is the different distance between the light reflex and the lower eyelid. And the MRD3 is the difference between distance between the light reflex and the upper eyelid margin with the patient looking up. So practically what we do is MRD1, that is with the patient looking straight. And usually it's around 4 millimeters. If it is 2 millimeters, the patient has got a mild ptosis. If it is 1 millimeter only, the patient has got a moderate ptosis. And if you can't see the light reflex at all, this shows the patient has got a very severe degree of ptosis. Just to give you an example, you can see in this patient on the right side, on both eyes, you can't see the light reflex at all. So it's a case of bilateral severe ptosis. Whereas this patient on the right side, you can see he's got MRD of around 2. So he's got a moderate ptosis in the right eye. Whereas on the left side, you can see his marginal reflex distance almost 1 to almost 0.5. So he's got a severe ptosis in the left eye. Again, a patient with a moderate ptosis. And this is a mild ptosis. You can see the left eye, it's completely normal, 4 millimeters, whereas the right eye, it's around 3 to 3.5. So depending on the amount of, the MRD, you can grade the ptosis. And it's important for you not to miss bilateral ptosis. Again, very important. Why is this important is, you can see in a case with a bilateral ptosis, when you lift one eye, you can see due to the Herring's reflex, the other eye will come down. So in a patient with a bilateral ptosis, you should always operate on both eyes. Don't do a unilateral ptosis correction. You can see, just to denote again, when you lift one eye, you can see the other eye droops down. So that's again very important. You check the LPS action, again, the very important documentation. You have to check the levator function. How do you do this? You ask the patient to look straight or look down and immobilize the frontalis with your thumb, and then ask the patient to look up fully at the ceiling. And do multiple checks. You have a scale with you and see the excursion of the upper eyelid. So this is how you do it. Immobilize the frontalis, ask the patient look down, keep a scale there, and see by how much the lid moves up. So this again is a small example. You see, look down and then keep a scale there and ask him to look all the way up and measure the excursion. And depending on the levator function, if it's 10 to 15, it is excellent. Below 4 is very poor. And in between 5 to 7 is fair. And 8 to 10 is good levator function. This is again very important because if the patient has got very poor levator function, you'll have to change the surgical plan. And in very young children, you have what is called the eye lift sign. You just evert the lid and see if the patient can spontaneously make it back normal by blinking. And to give you an example of good levator function and poor levator function, you can see the left eye of the patient with severe ptosis, the lid hardly goes up. And again, the lid crease is again the next important finding. It's a very important finding to document the lid crease. And the lid crease is the distance between the upper eyelid margin. The lid crease height is the distance between the upper eyelid margin and the lid crease when the patient looks down. In males, it's 8 millimeters. Its female is approximately 10 millimeters. Why is this important? Is in aponeurotic ptosis, the lid crease actually goes up. You have a high lid crease. And in the congenital ptosis, you have a very poor lid crease. You can't see the crease. You can see in this patient with the left congenital ptosis, you can see there's no lid crease at all, whereas in the right eye, he's got a good lid crease. And this is a patient with aponeurotic ptosis. You can see the high lid crease on both sides. And on down gaze, actually, the ptosis will improve on a congenital ptosis patient, whereas in aponeurotic, the ptosis worsens. So again, these are examples of difference between aponeurotic and congenital ptosis. You can see in a patient with the contact lens-induced aponeurotic ptosis, when the patient looks down, the ptosis actually worsens. And the lid crease is important because you need to place your incision matching the other opposite eye so that you give symmetrical lid creases. You can see this patient has been operated, but the lid crease is very low. This is a surgically induced crease. You can see a low lid crease, though the lift is reasonably good. The patient is not happy because of the difference between the lid crease height. Marcus gun phenomenon, again, is very important. You should not miss this. And the patient opens the jaw or moves the jaw to either sides. If the lid goes up and down, this patient has got a Marcus gun phenomenon. And this is important not to miss this because the surgical plan will completely change. You can see when the child masticates or moves the eye, moves the jaw side to side, you can see the lid flickering. Bell's phenomenon, you ask the patient to close the eye, you hold the upper lid and see if the cornea is going up. If the patient has got a good blink reflex, then the Bell's phenomenon is good. And if not, then you know the patient has a risk of developing exposure keratopathy when you operate. So you need to be careful. Check the pupils, very, very important. Can't underemphasize the importance of this. Check it in dark and check it in light, because in a Horner syndrome, you have an anisocoria in dark. And always again see the neck of the patient for any surgical scars or any signs of trauma. You can see a patient with a big scar on his neck and got a Horner syndrome. And for a Horner's pupil, you need to check the pupil size in dark. So dim the room lights and shine the light from the bottom. Don't shine it directly onto the eye of the patient. And you can see the normal pupil dilates well, whereas the Horner's pupil does not dilate. It's got a dilatation lag. So a Horner's pupil, the anisocoria is more prominent in dark. Whereas in a third nerve palsy, the patient has got dilated pupil. So when you shine light onto the eye of the patient, the anisocoria is more marked with bright light. Extraocular movements, the most important, check for elevation. Make sure the patient has got good elevation. Check all the gaze positions. Make sure the patient does not have any syndromes. Because in patients with third nerve palsy, usually the patient has got difficulty in all directions of gaze except abduction, and they are prone to developing what's called aberrant reinnervation. So after spontaneous recovery, the patient presents the ptosis, but on adduction or depression or elevation, the lid moves. So don't miss this. So you can see this patient with aberrant reinnervation, when the patient looks down, the ptosis improves. And also in patients with facial nerve palsies, which have improved, they can also have aberrant reinnervation. When they move the jaw, the ptosis changes. And don't miss the Duane's retraction syndrome. And always check the ptosis with all directions of gaze and see if there's any change. Myasthenia is a great mimic. You should never miss a patient with a myasthenia. All patients with ptosis, rule out myasthenia. Do the eyes test, very simple test on the OP. And if the patient improves well with 5 to 10 minutes of eyes application, then you have to suspect myasthenia. The other way is your fatigue test. You ask the patient to keep looking up for at least 4 to 5 minutes. And if the lid droops after the fatigue test, then again you suspect myasthenia, which you can confirm with blood tests and other ancillary testing. And always do the cover test and see if the patient has actually got a hypotropia, if he's got a squint with a pseudotosis. If the patient has got a hypotropia, if you cover the normal eye, the ptosis improves. And so the way to go is actually do the squint correction first and not do the ptosis correction first. You can see this patient with hypertropia with a simple squint surgery, his ptosis is also improved. Check corneal sensation, very important. Otherwise, you'll land up with serious problems when you do ptosis correction. Look for lag of thalamus. Always document tear film status before you operate. Very, very important again. And other tests are the neostigmine test or the tensilon test to rule out myasthenia. You can do the phenylephrine test to check for Muller's muscle action. And phenylephrine test is a simple OP test. You put a drop of phenylephrine or drosin. If the ptosis improves tremendously, then this patient will do very well with a Mullerectomy. Always document pre and post photographs. Might be very important. And do the FAT scan, the family album test. See the old photographs of the patient to see to get a clear idea of when the ptosis actually developed. And to conclude, always have a systematic approach, have proper documentation, and you will get very good results. Thank you.
Thank you, Senthil, for an elaborate talk on examination. I know it's a big topic, but you covered it pretty well. Thank you for that. Next on the panel is none other than Dr. Kasturi Bhattacharjee. I think I'll take 8 minutes to introduce her only. So, but to just keep it simple, we all know she's the head and director of academics at Shankardev Netralaya, also the head of the department, Orbital Ocuplasty Shankardev Netralaya. She's the president of the Asia Pacific Ocuplasty Society of India, also the chairman scientific summit committee, OPAI, and also the, at the ARC. So Dr. Kasturi, without further ado, I wanted to take us over the ptosis surgery simplified. I know your introduction is too long. I can do it in detail sometime later.
I'll really go fast because of the interest of time. We are going very slow. So I'll finish it. If I cross 8 minutes, Shubhra, please stop me. So
Sure.
can you tell me on the floor? Am I audible?
Yes.
So we
Yes,
all currently there are several treatment options for the ptosis, and the selection of one depends on multiple factors. The most important being, which Dr. Senthil has already mentioned, the grade of ptosis, and second most important being the levator function. So one of the most common approaches that we do are the anterior approach, which can be a LPS resection of plication, the frontalis sling, which can be done with the solid silicone and the fasciolata. And nowadays, all of us are moving to the frontalis muscle flap advancement. However, the posterior approaches are also very useful, which I do for many indications, especially the posterior white line advancement and the MMCR, and I've abandoned doing the Fasanera servlet operation. So this is a very simple surgery that I like to show, which is a very common where you have a good amount of levator function. If the amount of function is more than 4 or 5 millimeter, we all prefer doing a levator resection where we expose the levator aponeurosis, and if it is too much of ptosis, we also expose some amount of the levator muscle, and then you titrate the amount of resection that needs to be done. We pass three suture. Initially, in my practice, what I do, the first 3 sutures, I usually use a Vicryl, but please remember the Vicryl has a tensile strength of only 2 weeks. So it is always advisable that finally you also give the Prolene sutures. So when you titrate, because sometimes we need to keep on opening to see the actual length of the resection that has been done correctly. And if the patient is under local anesthesia, one good advice that I like to do is make the patient sit down, because the position of the lid differs in the sitting and in the supine position. So once you're sure of the position, you do the excision and then you put the final Prolene suture and go for the skin closure. And you see a very adequate correction. And this is under the senile ptosis that you can see a elevated reinsertion has been done. But what I want to show that the most common surgery is the frontalis ring, which is done by silicon rod and which is usually contains where we do a shape in the form of a pentagon and we use a silicon rod. This is approximately 20G stainless steel needle having a length of approximately 40 centimeter, diameter of 800 micron. And we pass this in this very simple, it can be done by any general ophthalmologist. And also I feel that all the surgeries we are showing here, it is basically meant for the general ophthalmologist. So you pass it in the form of a pentagon and you titrate how much amount to lift. Usually advisable to do a 0.5 millimeter overcorrection because the patient is in this supine position. And once you are very sure of the position, you can close it and give the frost suture. It is a beautiful surgery, but what we don't like are the scars. You can see the scars in the forehead and also situation like blepharophimosis. We use a sling, but this time because the lids are very thickened, we use something which is known as the fascia lata. So this is little advanced for the general ophthalmologist, but this is one of the options that I like to mention you, where we use a fascia lata for a sling and you get a very adequate correction. But again, what we don't like, giving a very good correction like blepharophimosis, you see this child after 4 years, we don't like the scar. So what are the major drawbacks? We found that one is the legophthalmos, one is the scar, and that's what we prefer nowadays, that we use a frontalis muscle flap advancement, wherein we make an incision and then we expose the frontalis muscle and use this frontalis muscle, which we pull down and suture it to the tarsus. And once you do it, you can get a very adequate correction. You can usually put 1 or 2 sutures. If I prefer using fiber of acryl here and usually put 2 sutures, and you can see a very good correction of the ptosis. The beauty of this surgery is that the correction is good and they do not have legophthalmos. This is really what we want in pediatric population, because it is very difficult in case they have a legophthalmos, they are not able to express. And you see the beauty, almost one side LPS are done, one side frontalis muscle advancement, and you can see they do not have legophthalmos. They can close their eyes so well. Another girl with no legophthalmos. So this is what I am doing, and it can be done in very complex case where when you have something like a blepharophimosis, where along with the frontalis muscle flap advancement, we can also correct the blepharophimosis, do a epicantoplasty, and this is how it is being done. But what I like to share with you is the quality of life. If this child is at the 10-day post-op, you can see that the board has got no scar. And if you
दरअसल ख्वाब की बात हो चलती मेरे ख्याल वसागात हो.
So this is the beauty of the surgery. Little bit about the posterior approach, the posterior wide line advancement. This is a very beautiful surgery. I do it when you have approximately a LPS section of 8 millimeter or more. You give an incision the same way how we expose the aponeurosis. This is the posterior way you're exposing. So now what you do is something like a plication. Depending upon the amount of ptosis, you can plicate this LPS through a conjunctival approach and then you bring the sutures out. So this is a very minimally invasive surgery which gives a very adequate correction. Like this child, you can see a minimum ptosis and you can see the beautiful correction. There is no scar, only the suture line which gives a very good lid scar. Lid crease. So this is what I have been doing it as a posterior approach, and definitely Senthil has already shown the positive phenylephrine test. So in such situation, what we do, the gold standard is MMC, or molar muscle conjunctival resection. This is also a posterior approach where you go through the transconjunctival approach, expose the molars and the conjunctiva, where 4 millimeter excision corrects 1 millimeter of ptosis, put the Putterman clamp, pass a absorbable suture at the single throw or double throw, and take out the knot through the skin. And usually I try to reuse this on the table, whether approximately 8 millimeter or 6 millimeter, whatever I plan has been excised. So then I'm sure of the post-operative result is a very, very predictable here. I have also done blepharoplasty for her because of the dermatochalasis, and you can see the beautiful result before and after the surgery. Just to conclude, Ptosis surgery really helps in multiple improvement of the functional improvement, the visual improvement, which really improves the quality of life, and the type of the surgery depends upon the severity of ptosis and the surgeon's preference or expertise. Thank you very much for your patient hearing.
Thank you, Dr. Kasturi. That was well within the time limits. Do we have Dr. Akshay Nair here on the panel?
In some other session, we'll go to the next presentation, and once Akshay joins, we can have the discussions.
Sure.
Can I talk a little bit?
Yes, ma'am.
Okay. No, I would congratulate Sendil for having shown a beautiful method of preoperative assessment. As everyone knows, that ptosis is one condition which is very common, and it is seen the maximum number by the oculoplastic surgeon. And all of them have to be referred by the general ophthalmologist when they identify ptosis and refer it. So the method by which Sendil had described how to do the assessment is extremely good. I congratulate Kasturi for showing the beautiful results which she has shown in all the cases. But unfortunately, that does not happen in each and every case. So one has to counsel the patient beforehand as to what are the complications which can occur in any case of ptosis, and patient should be prepared for a second surgery or even third surgery. That is something which has to be explained. The general ophthalmologist have to identify the ptosis and decide when exactly they should refer the patient. It depends upon very many factors like the age. Earliest age we like to operate is 3 years from the preschool stage. Sometimes even earlier if the ptosis is very severe. So that is also another point which has to be very clearly explained by the ophthalmologist. Thank you very much.
I think we'll go to the next presentation by Dr. Katie. So Dr. Katie is currently working as a full-time consultant and in charge of the fellowship training program in Orbital reconstructive ACT surgery. She had done her fellowship in training, fellowship training with Dr. Bhupendra Patel at Tumors Eye Center, USA, and also with Dr. Bita Ismaili at Anderson Cancer Institute, USA. Her areas of expertise include the orbital connection with oncology, eyelid surgery, and diagnostics, and she has published in numerous journals. So over to you, Katie.
Thank you so much, ma'am, for the kind introduction. Thank you, Dr. Kasturi and Dr. Prashant, for giving me this opportunity to be part of this AIOS. I'm really glad I could be a part of this. You're able to see my screens?
Yes.
Yeah. So today I'm talking about evaluation of proptosis. So as general ophthalmologists, you're going to see proptosis at some point or the other. They're very common to see a patient with proptosis. So like all the previous speakers have elaborated about how it is important to take history, I'm also going to talk about how it's important to examine a patient of proptosis. But before we go into what is proptosis, first we need to know what the definition of proptosis. So proptosis is basically the forward protrusion. But we also know there's a term called exophthalmos, which is also a forward protrusion. So proptosis is generally protrusion because of a space-occupying lesion, whereas exophthalmos is a protrusion generally associated with thyroid ophthalmopathy. And the other term that we know is dystopia, which is generally a non-axial proptosis. So an eccentric proptosis is called dystopia. And when we talk about proptosis, it's important to know also about what are the pseudo-proptosis that we know. So you can actually not have a true proptosis, but a false proptosis. So here we have a patient who doesn't have proptosis, but is nothing but an ipsilateral eyelid retraction, which is giving the appearance of a proptosis. Patients with myopia and ophthalmos, because of the large eyes, they can also present with proptosis. A patient who has a ptosis in one eye, sometimes it is mistaken for proptosis of the particular eye. A contralateral enophthalmos or microphthalmos. Enophthalmos maybe because of fracture or microphthalmic eyes. Then it gives the appearance of a contralateral proptosis, and shallow orbits. This is also not a true proptosis. So how do we classify proptosis? So proptosis can be classified based on the age of onset, based on the displacement, laterality, etiology, the onset, and pulsations. I'm going to look into each of these now in the coming slides. So based on age. So just by the age, it's easy to bring down your differential diagnosis. So when you say congenital proptosis, generally the only few things that are there are teratoma or a congenital cystic eye. Whereas in children less than 2 years of age, it is important to keep in mind the differential of capillary hemangioma. In children in the first and second decade of life, the most common cause generally is going to be cellulitis or dermoidosis, followed by vascular like lymphangioma, or sometimes they can be tumors such as a rhabdomyosarcoma. In the middle age group, the first thing we need to remember is thyroid orbitopathy, followed by lymphomas. Whereas in older age groups, it is important to keep in mind metastatic lesions. We can classify them based on etiology into inflammatory, vascular, cystic lesions, benign, and malignant. So in each of these, it's important to remember the common ones. So for infections and inflammatory cellulitis and thyroid disease and IOID become the most common. Whereas in vascular, you should always remember capillary hemangiomas, lymphangiomas. In cystic lesions, dermoids. Whereas in benign tumors, they can be lacrimal gland pleomorphic adenomas. Whereas in malignant, they can be lymphomas. So most proptosis that we see are generally unilateral. So if a person actually comes to you with a bilateral proptosis, it further narrows down your differentials, like thyroid for inflammatory, or sometimes in case of bilateral, you see a supratemporal lesions. You should always remember things like sarcoidosis and Wegener's. Neoplastic lesions like lymphomas. Structural can be craniosynostosis. And when it's vascular, bilateral, always think of carotid cavernous fistula. Now, based on the direction in which the globe is displaced, also we can think of where the lesion is arising from, and that also helps to give us a few of our differentials. So if you look at this, here you have a patient who's having a superior dystopia, and there is some lesion arising in the inferior orbit. So immediately it suggests that there's a lesion arising either from the lacrimal sac region or from the floor or from the maxillary sinus. This patient actually had a maxillary sinus carcinoma. Here you have a lesion who's patient having a downward and outward displacement. So the lesion is basically arising supranasally. This is a mucocele. Here a lesion patient with an axial proptosis, and you can see imaging. There is an intraconal lesion which is suggestive of a cavernous hemangioma. And here a down and in displacement with a lesion in the lacrimal gland fossa region with erosion of the bone. So you can think of lesions such as an adenoid cystic carcinoma. Onset is also very important because based on the onset, you can narrow your differentials. And so if you have lesions with acute onset, most commonly it's going to be either an infection or an inflammation. In neoplastic lesions also, you can have an acute onset, especially in those which rapidly progress, or if there's going to be a necrosis within the tumor. When you say vascular lesions which have acute onset, most often lymphangiomas which have an acute bleed into the lesion, or it can be post-trauma, or a surgery where you can have a retrobulbar hemorrhage or a subperiosteal hematoma. Subacute and chronic lesions which have a slow progression over time, generally they are going to be more benign and not something like a malignant lesion. So you always think of lesions like thyroid or other benign lesions which can involve the orbit. Again, it's important to look for pulsations. Now, pulsations, again, you should remember that you can classify them into true and transmitted pulsations. Now, true is because it is directly coming from an arteriole. So it can be carotid cavernous fistula or an ophthalmic artery aneurysm. Whereas transmitted is basically a pulsation being transmitted from the CCF. So meningoceles, encephaloceles, or a sphenoid wing aplasia. So any patient, it's very important to be systematic in our approach. Start with history taking, then local examination and ocular examination, followed by systemic examination. And then you move on to investigations like imaging. So in history, first ask the patient when he first noticed the swelling, what is the duration, months. So that tells you whether it's acute or whether it is a subacute or a chronic lesion, how it has progressed, rapidly progressed or slowly progressing. Associated symptoms like pain, that gives you an indication like IOID, or there's a perineural invasion like in adenoid cystic carcinoma. Decrease in vision indicates that the optic nerve is being compressed and the lesion is intraconal. A double vision indicates that the lesion involves the muscle or something is infiltrating the muscle. Very important to ask for aggravating relieving factors, especially for orbital varices. Patient will give you a clear history that when he bends down, he will see that the lesion is increasing in size. Systemic diseases like thyroid. So if a person gives history of thyroid, then it immediately says that the proptosis probably is due to thyroid eye disease. Tumors for metastatic lesions, any inflammatory diseases like sarcoid. Inspection, important to look for axial or non-axial. In patients with thyroid, look for the eyelid retraction, lateral flare, look for lag ophthalmos. Always do a motility test to look for any movement restriction associated with the proptosis. Look for signs of inflammation on inspection, any redness, any angry looking eye, and generally examine the mass from external, where it is located and what is the general outer appearance. In palpation, you actually go ahead and examine the mass, check for the consistency, whether it's soft, it is firm. That gives you a clue whether it's cystic or whether when firm masses, that means they are generally malignant. If there's tenderness, most often inflammation. Any compressibility, reducibility. Always palpate along the orbital rims. It gives you indication whether you're able to insinuate your fingers or not. Resistance to retropulsion. That means if there is resistance to retropulsion when you place a thumb and press posteriorly, posterior displacement of the globe, if there's resistance, that means there's an intraconal mass. Any pulsations and thrills which can be determined by auscultation. So now actually coming to the measurement of proptosis. So simple.
Yes, sorry to interrupt. Can you be just a little fast on your talk, please?
Sure, ma'am. So measurement, always simple things like a worm's hole or a bird's eye. A very simple instrument that can be used is the hurtles, which can help to measure the proptosis. A two-ruler test can be used to see for the amount of dystopia. This is the Valsalva that I was talking. You can ask the patient to bend forward for 30 seconds, and then you can clearly see how a person who had a superior sulcus, it fills up. So this helps to clinch the diagnosis of a varix. Always do a thorough ocular examination. These are typical corkscrew vessels, which you generally see in CCF. IOP examination is important, especially in thyroid patients. A thorough regional and systemic examination is very important, especially for lymph nodes in patients with, if you're suspecting malignancies. So there are a few simple examples. Here's a capillary hemangioma, which responds very well to oral propranolol. There's a child with acute onset proptosis post upper respiratory tract, very typical of a lymphangioma, which shows fluid levels. Child with sudden onset post-trauma, this is very typical. You show the retrobulbar fat stranding. It's an orbital cellulitis, most commonly post-paranasal sinus infection, but can also occur post-trauma. Responds very well to IV antibiotics. Rapid onset in a child, always think of rhabdomyosarcoma. Bilateral proptosis in children with fever, leukemias are important DDs to be considered. This is a very typical dermoid which occurs generally in the external angular region. Thyroid eye disease, which is something which you will see very commonly in practice. You will see enlarged extraocular muscles. This has to be differentiated from IOID, where you generally have tendon involvement, whereas in thyroid you don't have. There you have retrobulbar pain, and here you have pain on ocular movements. I'll skip all of this. Axial proptosis, typical is cavernous hemangioma in a middle-aged female. This is very typical in proptosis, always ocular examination. Look for salmon patch, which helps to diagnose a lymphoma. Okay. Corkscrew vessels, I have already discussed. Patients in the middle-age group, well-defined lesions in the supratemporal aspect with bony remodeling, always think of a pleomorphic adenoma. Whereas same thing if you have bone erosions, ill-defined adenoid cystic carcinomas. Metastatic lesions have to be considered in adults, especially in older age group people. Always think of metastatic lesions. So my take home here is you can have a wide range of lesions which can cause proptosis, but the most important thing as clinicians that we need to know, first thing is the history taking and a clinical examination. So it's important for us to know where tumors are located, and based on that, the onset of the disease, how it progresses, clinical features. With these three things itself, most often the diagnosis can be made. But the most important is knowledge. We need to have a thorough, good knowledge about all of these things to come to a proper diagnosis. Thank you.
Thank you, Kirti. Is Preeti there? Preeti, you are the discussant for the... No, sorry, Dr. Usha came as to talk right now. Yeah. Ma'am, you're mute.
Yeah, I'm here, very much here.
Am I unmuted? Can you hear me now?
Yes, doctor, you're audible.
Yeah, we can hear.
So I take this great pleasure to introduce Dr. Usha Kim, who has the Department of Orbit, Oculoplasty, Ocular Oncology, and Oculoprosthetics at the reputed Irvine Eye Hospital. She completed her graduation from the PSG Institute of Medicine, and then went to complete her residency in ophthalmology at Irvine Eye Hospital. Later, she underwent specialized training in the field of orbit and oculoplasty under the guidance Professor William Stewart at the University of California, USA in 1998. Dr. Usha has started the Department of Orbit and Oculoplasty at Irvine Eye Hospital. Under her leadership, this department has become a center of excellence in the treatment of the rare ocular condition that have to do with trauma, congenital anomalies, cancers of the eye, and definitely eye genomics. She is the past president of Oculoplastics Association of India, a great surgeon and a prolific orator. Over to you, Usha, please.
Thank you, Kasturi. That was an excellent introduction. And thanks, Dr. Prashant, for giving me this wonderful opportunity. Can you hear me and see the slides?
Yes.
Yes. Okay. So I think it's a big topic, and I'm not very sure that the general ophthalmologists will like this presentation very much, because they are not going to be doing it, but at least it will be useful for them to refer patients and also see what to expect and also help in counseling the patients to what to expect. So if you look at the approaches to orbit, it's usually anterior. You can have a superior approach, medial, inferior, and a lateral approach, depending upon the site. As was presented by Kirti very rightly, it's the location which is very important for us to venture into any surgical procedure. So the most common, initially it used to be a skin approach, but now we've moved more towards transconjunctival approach for most of the surgical procedures in the orbit. So when we started off, we used to do a lateral orbitotomy in most of the conditions, and we used to have the stellar right, which used to be a big incision. And then we moved over to Reese approach. And then later on, we moved to various other approaches, which I would like to share with you. Now you see here, there's a hypertropia here, and there's a bit of a fullness in the inferior orbit. And you can see on imaging, which is very, very important for us to plan surgically. And this is a lesion you can see on the image. And this is the surgical approach that we have advocated in this particular case, where this patient undergoes an inferior corneal, Yeah, so actually we do an inferior corneal, inferior conjunctival approach, and we remove the tumor surgically. And I think this video is not playing, but then this is the postoperative picture you see in this particular patient. Right the next day, postoperatively, you see this picture. So it's almost like it's not done. And now this is another scenario where you see an inferior orbital lesion, and you can see that on imaging very clearly the lesion is here. And this is the surgical procedure. Sure, why this is taking some time. Can I just end and restart, if you don't mind? Can I stop share and do it again?
Sure. Please go ahead.
Yeah, I'm very sorry for this.
In the meantime, Preeti, would you like to discuss the presentation?
Yeah, I think I can discuss Kirti's topic. When it was an excellent presentation, she covered the entire examination, which is quite a huge topic. But few things that I wanted to point out is that shallow orbit is very, very common. Many a times we get referred patients with proptosis, but they are actually shallow orbits. So when you see very symmetrical proptosis in both the eyes, it is very often just a shallow orbit, and they don't need orbitotomy. So that is one point that I wanted to highlight. Even a lower lid retraction gives an appearance that the eyeball is proptosed, and that has to be picked up in clinical examination. Also, sometimes skin changes give you a clue. So when you see a small reddish discoloration, it could be a hemangioma versus a lymphangioma. And a very good history is history of upper respiratory tract infection causing increase in the proptosis. That tells you that it is a lymphangioma, and it's a very typical history which is given by most of the lymphangioma patients, that it worsens with a cold or cough, which the child often has. And also, I would like to stress on pre-op counseling. So when you see a patient with proptosis, and when you have diagnosed and decided to do a surgery, pre-operatively, you must really counsel the patient well and tell them that there can be loss of sensation in the areas. If you have a large orbitotomy that you're doing, you may sometimes, the zygomaticotemporal or the zygomaticofacial nerve can be affected. And I think that is a very common problem which the patient comes with, and they hop from surgeon to surgeon saying that, the surgery went on well, but I can't feel, I have altered sensation. It's a very small thing, but if we tell this to the patient before the surgery, it really helps the patient to expect that in the post-op period. And also, I think Madam is going to discuss the surgery.
Usha is ready. So let us go back to Usha.
Yeah, sorry about it. So I just wanted to show only videos of cases where we've this is a scenario where we have a lesion right beneath the globe inferiorly, and all we needed to do was a transconjunctival approach where we go do a phoenicial approach inferiorly and get the lesion out. And this is the immediate post-op picture that you see on over here. And you can see that the fullness is gone, the hypertropia is gone, and this is the day 1 post-op. Now this is another scenario. It's a young girl with a lesion inferiorly. You can see correspondingly a lesion in the imaging, and this is the approach that we have taken. Again, inferior phoenicial approach, transconjunctival, and the lesion is well exposed, and without much damage to the muscles, you just have to excise this lesion in toto. It happened to be a schwannoma. You can see those yellow globular lesions, and you can excise it in toto. And this is the immediate post-op. So this is the lesion here, a corresponding lesion here, and you can see that the lesion is completely gone and it's almost asymptomatic the next day. Sorry. Again, another scenario where you have this proptosis, you have a medial lesion here, and all you needed to do was a conjunctival approach, and you can excise the lesion in toto. And this is the immediate post-op. Here you see this, and this is late post-op. So this is the proptosis, this is the lesion, this is immediate post-op, and this is late post-op, and all through a conjunctival approach. Now here we have another scenario where this patient has, if you notice, a minimal elevation restriction, and on imaging she has a lesion in the superomedial aspect, and you do a minimal lid crease approach, and you can actually identify the lesion, expose it, and remove it in toto. And this again happens to be a schwannoma. So this is the lid crease approach where you would almost have very minimal or no scar sometimes. So I always have some redundant tissue left along with the lesion so that you can use that tissue to hold the lesion. And that's the entire lesion removed, and you can just close the this is another lesion. You can see there's proptosis, and the lesion is right behind. So you just have to do a capnotomy, and then you can expose the lesion, and this happens to be a capillary hemangioma, which is a very, very easy lesion to be removed. But then you have to carefully dissect it out, and you have the lesion in toto. And it looks quite scary on the imaging, but then this is the immediate post-op picture that you have. Now you can also do an optic nerve sheath decompression.
Registered for
Sorry? Alright, I'm going to skip this because it didn't seem to work. This again doesn't seem to. For some reason, it's refusing to open. Anyway, again here, what we need to do is just a conjunctival approach where you can actually approach the optic nerve, and you can make a fenestration in the optic nerve sheath, and you can do a decompression very easily. Probably I can show the, yeah. So now here again, this is an orbital floor fracture. Elevation is restricted. You approach transconjunctivally, and you can identify the defect in the floor and make a template, use any material that of your choice and then position it, and you can close the defect comfortably. And that's the closure. You can see that there is a good elevation or immediate post-op. Now, this is another scenario where you have such a huge lesion. This is a lesion of the lacrimal gland. This is a 45-year-old male who had a large lesion in the lacrimal gland region. And all we had to do was a canthotomy and then a transconjunctival approach laterally. And earlier we used to do the bone breaking lateral orbitotomy. Now with very meticulous conjunctival approaches, we are able to remove even such large lesions in toto, in fact, without rupturing the lesion. So this entire lesion comes out without much of an effort, and that's the size of the lesion you can see on the table. And you can close it without much of a residual complication for this particular patient. And you also have some combined approach. When you have lesions like this, you do a combined inferior and superior approach. Earlier, we used to have this lateral orbitotomy where we used to start off with the stellar right, then we went in for the Reese approach, and then we used to do coronal scalp flap, and then we used to do combined flaps, and they have not become redundant because we need to use some of these approaches in cases where we have apical lesions or when we have very complex situations. Navigation assisted surgery, I think Preeti is very an expert in this area. So this has also been used in some of the scenarios in the approaches to the orbit. So post-op care usually requires head elevation. There'll be a lot of edema. All of these have to be instructed to the patients, but eventually fades off, especially with the advent of conjunctival approaches. The edema part has been almost redundant, and then you use ice compress to reduce the edema and the pain. And we do have post-op complications. We don't see it as much as we used to see with the external approaches. But what we need to advise to the patients is you have to get a consent before any of these surgical procedures, because you can have failures in any of these procedures and you can have a visual loss because you might inadvertently damage the optic nerve. So all of these have to be explained to the patients well in advance. Ptosis, diplopia, and then you will have a dilated pupil due to the ciliary ganglion injury. All of these have to be explained to the patients prior to the surgery, because once you do it prior to surgery, it's always an explanation. But once you do it after surgery, it becomes an excuse. So a proper counseling prior to surgery is very, very important, and it becomes part of your surgical protocol. Thank you very much for this opportunity again.
Thank you, ma'am, so much. And in the paucity of time, let's move ahead to the next session. And I invite Dr. Neelam Pushkar, Dr. Darjani, and Dr. Savit Desai to be on board, please. Dr. Neelam is the faculty at All India Medical Institute and exclusively works on retinoblastoma. Dr. Darjani is the director at LV Prasad and is doing awesome work with the sockets and the orbital surgeries. And then we have Dr. Savit Desai from Mumbai, and who has been our faculty for many years. So over to you, girls. Please take the session over. Dr. Neelam, is she there?
Yeah, good evening, everyone.
Yeah.
I'm just sharing my screen. Thanks to Dr. Prashant and Dr. Kasturi for the opportunity. I hope you can see my screen.
Yes, yes, we can see your screen. Yeah.
Okay. So I'll be talking about imaging modalities in orbital tumors. So we have wide range of tumors. I'll not go into details of all this. It has been already dealt with. So coming straight to the imaging. So baseline imaging, I must say, is the contrast enhanced CT scan because it has the advantages. Mainly that it provides both the soft tissue and bone details, as you can see here in the pictures. And we all know it is well tolerated, rapidly done, easily available, less costlier than MRI. Bone windows will tell you about the bones, and the only disadvantage is the radiation exposure. So most of the tumors we can see on contrast enhanced CT scan, we can diagnose, we can have good clinical differentials. We know about the bony changes, and these are some common tumors which we come across. So the bony changes, which specifically we want to see on CT scan, which we can miss on the MRI, is, as you can see here in the lacrimal gland tumor, the presence of this fossa formation here tells you that it is a long-standing lesion and it's a benign lacrimal gland tumor. And here, in contrast, you can see that there is thinning of the lateral wall of the orbital rim with erosion, and the lesion is also not very well defined. So this is a case of adenoid cystic carcinoma. And in non-Hodgkin's lymphoma, we know that what we see, what we expect on CT is the homogeneous appearance of the tumor, and it is usually ill-defined, and it molds with the, the eyeball contour, as you can see here, that the contour of the eyeball is so nicely maintained, and bilateral, lesion. And most of the cases we can diagnose on imaging. So CT also helps in, identifying the calcification, phlebolettes, and, the bony lesion. As you can see here, the arrow indicates the presence of osteoid matrix in patient with osteosarcoma. Then you can see here the presence of periosteal reaction, which probably you will miss on MRI. And here you can see the osteoma, which is a bony lesion, and arising from the frontoethmoidal bone. And below picture, you can see presence of calcification, which helps in clinching the diagnosis of meningioma. Then the size of the and the presence of the bone defect you can see on CT, and as you can see in meningocele over here, and in a patient with dermoid, you can see that there is a bony defect. And the Hounsfield value, which we see on CT, which is basically radio density, and the lesion, especially the dermoid cyst, we can very clearly diagnose, with the help of the Hounsfield value. We see dark cystic lesion, as you can see here, and which is absolutely roundish. And if you see the Hounsfield value, which is generally mentioned by the radiologist, you will see that it is in minus. So that clinches the diagnosis in 99% of the cases. This is another patient with the dumbbell dermoid. And then MRI also has some advantages, but as I said, CT is the baseline. Basically, we know that it has no radiation exposure, and we can see the soft tissues better. But the disadvantages are that the bone cannot be visualized properly, and it is difficult to perform, longer duration, costlier, and sometimes it is also difficult for the surgeon to interpret. But there are some indications, like for intracorneal tumor, where we want to know exactly where the optic nerve is, and we want to know the extent of the lesion, whether it is going intracranial, and sometimes in difficult cases where we are not able to diagnose on CT. So like these are some examples. You can see meningioma here. You can see the optic nerve within the tumor. The meningioma is engulfing the optic nerve. So this is a tram track sign, which you can see in this patient. And this is a patient where there is a glioma, which is arising from the substance of the optic nerve. So what you see is the expansion of the optic nerve. And posteriorly, you can see the optic nerve is normal. So how clearly you can see on MRI. So intracorneal lesion, definitely MRI has a role. It adds on to the information, and it helps in the, making the accurate clinical diagnosis. Contrast is a must whenever we advise any imaging MRI or CT scan, because it will let us know about the cystic or solid tumor, the vascularity of the lesion, because as orbital surgeon, we would like to know the vascularity, and any feeder artery is there or not surrounding inflammation, the extent of infiltration, cavernous sinus involvement. So contrast is a must. Without contrast, you are giving like half information to the surgeon. So some special investigation like with and without Valsalva, generally we want to see in patient where we are suspecting viruses. So if without Valsalva, you see that the lesion is so small, but with Valsalva maneuver, you can see that the lesion has expanded. So this basically clinches the diagnosis of viruses. Ultrasonography is very handy tool which we have, and it is a something which can be easily mastered, easily performed, less expensive. There is no radiation exposure, and the main advantage is that it tells us about the internal architecture of the tumor. So this is something which we routinely do in all our patients. And color Doppler, rarely it is indicated where we really want to know about the arterial flow and venous flow. This is just some example where you can see that how beautifully ultrasound, clinches the diagnosis. Like if you see here, there is, lymphatic malformation, there is expansion of the orbit, which suggests that it is a long-standing lesion. And you can see that there are, some roundish lesion, not very clear. On MRI, you can see that there are hyperintense, cystic areas on T2 images. But on ultrasound, if you see, there are clearly you can see the microcystic and the macrocystic area which clinches the diagnosis. So this is how ultrasound really helps us. Cavernous hemangioma, again ultrasound, you see the dancing spike, because if you see the cut surface of cavernous hemangioma, what you see is the honeycomb spaces, which are basically cavernous spaces. So on ultrasound, what you see is the dancing spike like this. So this is all because of the septae and very regular spaces which we have. So this is how the solid tumor, especially the schwannoma, we can differentiate from cavernous hemangioma, and we are almost 99% sure that we are dealing with cavernous hemangioma. And schwannoma, you can see that usually seen as a roundish lesion like this. And on ultrasound, you see hypodense areas, but they are not as regular as you see in patients with cavernous hemangioma. Color Doppler, again, is a few indications, especially in orbital varices, where you do with and without Valsalva, and you can see that there is a dilatation of the blood vessels. So take-home message is that patient workup is very important, so that we, give at least some good clinical differentials to the radiologist, who will further help us. And as I said, CE-CT is preferred in orbital tumors. Without contrast, there is no point. It's like, half information to the orbital surgeon. Ultrasound aids in establishing the radiological diagnosis. MRI helps mostly in intracorneal tumors and to know about the extent of the lesion, especially intracranial. And discussion with radiologists helps in, having a proper management plan. Thank you so much for the opportunity.
Thank you, Dr. Neelam. Over to you, Darshini, for your talk, please. Darshini, you are on mute. You're on mute.
Sorry, thank you, Dr. Kasturi. Thank you, Dr. Bavankule, Shubhra, and Savri. So fantastic to see you guys all the way from across here. So I'm going to, without much ado, get going straight to the part that I've been tasked with. And I'm going to talk to you about socket surgeries. I don't have any financial disclosures, and I want to talk to you on these 5 points that I've listed out for you. In my mind, an ideal socket is the one where I have correctly identified the pathology. I've done a timeout before operating on the patient to ensure that nothing is wrong. And I'm giving the patient a good volume, good surface area, an excellent prosthesis, and no eyelid anomalies at the end of my surgery. Are my slides moving? Okay.
Yes.
Yeah. So the first part is most important, and that is to correctly identify the pathology. Even if you have a suspected intraocular tumor, even if it's not proven, I would go ahead with an enucleation. In cases where I've completely ruled out an intraocular tumor and it's a end-stage eye, I would prefer an evisceration because it's less devastating on the orbital anatomy. And obviously, for certain cases, you go ahead with an exenteration. So I'm taking you through the steps of enucleation. Please stop me if you think my video is not playing. I'm guessing everything is fine. So it begins with a peritomy, which is 360 degrees to separate the conjunctiva and neurons from the ocular surface. In all cases of enucleation, you want to be extremely careful. Use a blunt tip scissor because you don't want any perforation. Following that, you separate the posterior tenons in the 4 oblique quadrants between the extraocular muscles and then start tagging the muscles. I typically go in the order of MILS. So you are seeing the medial rectus tagged with a foro silk and a second suture taken 6 to 8 millimeters from the silk, which is typically a vicryl suture or the myoconjunctival suture. And between these two sutures, you see the muscle is dissected. So what you have done is you now have the foro silk, which helps in giving you traction anteriorly and is holding the muscle stump while you dissect the optic nerve. But at the same time, the muscles are not lost. They remain tagged with this vicryl suture, which helps in improving motility. And I'll get to that in just a bit. So a little bit of fast forward here, just to tell you that all the muscles are, all the 4 external recti muscles are tagged with vicryl, but the obliques are just kind of chopped off because they don't play much role in anophthalmic sockets motility. Now, these silk sutures help you give the anterior traction, which allows you to go deeper into the orbit and get a long optic nerve length, especially in cases of tumors where you want a larger stump of the optic nerve. And then you go posteriorly and try to cut the optic nerve with as minimal number of cuts as possible, bluntly dissect adherent tissue around the eyeball and remove the globe and send it for pathology. Now, this is your posterior tenons inside which you saw the yellow globules of intraconal fat. That's how you identify your posterior tenons. You place the implant in and you close the posterior tenons over it with interrupted sutures, typically a 6-0 vicryl. Once your posterior tenons has been completely closed, comes in the role of those myoconjunctival sutures that I spoke to you about, which are the other sutures which are holding the recti in place. Now, what those myoconjunctival sutures do is, you can see over here, they are exteriorized in the respective fornices. So the 4 recti are now going into the 4 fornices where the prosthesis is going to sit and are going to help translate the motility onto the prosthesis. Once the myoconjunctival sutures are taken, the anterior tenons is closed with interrupted 6-0 vicryl sutures. And then the conjunctiva is closed with a running suture, typically again an absorbable vicryl suture is what I like to use. This is the conjunctival closure. And then I typically insert a conformer in all patients and do an intermarginal tarsorrhaphy, which stays in place for about a week. Socket surgeries are quite painful, and I like to end the surgery with retrobulbar ropivacaine, a long-acting anesthetic, to keep the patient comfortable in the post-operative period. That was about enucleation, and the most important part there was the myoconjunctival technique. Okay, the video on evisceration is not playing, but I have backup here in terms of images. So the initial steps remain the same, where you dissect the conjunctiva, peritomy, and the posterior tenons in the 4 oblique quadrants. And then you remove 360-degree corneal button, and then you scoop out the contents from the eye. After that, you wash the scleral cavity with alcohol and then saline. And this is the most important panel where you're now creating scleral flaps. What these scleral flaps do is they help release the sclera from the optic nerve posteriorly, and therefore the sclera can move and cover the implant and you have a tension-free closure. This allows you to place in a larger implant, which obviously gives a better aesthetic outcome. What I've done here is I've made 4 scleral petals. You can see these 4 flaps. So that's a radial incision from the sclera to the optic nerve, and then a circumferential incision around the optic nerve. Placed a desired implant and close the flaps over it, and the rest of the closure is exactly similar to what you do in an enucleation. And this animation shows you what happens when you make these petals and disinsert the scleral flaps. You can actually bring them anteriorly over a large implant and therefore give a better cosmesis to these patients. I just briefly wanted to talk about the armamentarium that you have for secondary reconstructions of the socket. You can place in secondary implants, or you can put a dermis fat graft. You can augment, the volume in a socket which has a smaller implant by either putting in a second porous wedge along the floor, or harvesting fat from the patient, or just simply putting in a hyaluronic acid gel filler. And I'll end with this one surgery, which has now become my favorite for all secondary reconstructions where you have surface as well as volume loss. I typically tend to do these flaps of conjunctiva and tenons, and then I place an implant inside the socket. So I am doing a secondary implant here to give the volume, and I augment the surface with the help of a mucous membrane graft. So once you've made the flaps in conjunctiva and tenons and identified the central space, you place your implant in. Those two flaps of the conjunctiva that were made go into the fornices to give you surface area in the fornix, and the bulbar conjunctiva is reconstructed with the help of a mucous membrane graft. So that's the conjunctiva going into the fornix with the help of a fornix formation suture, and then you harvest mucosa either from the lip or the buccal area, and you place it over the center of the socket bed to give you the surface enhancement. So this works in terms of giving you both surface as well as volume enhancement for a patient with contracted socket. As against this, you can always use dermis fat graft also. I have recently, come to realize that in my hands, dermis fat graft gives a little bit more necrosis than what I would like. And I find that this technique of secondary implant with a fornix formation suture and mucous membrane graft works better for my patients. I just wanted to show you some images of patients where a combined surface as well as volume augmentation is done, and just also wanted to show you how seamlessly the mucous membrane graft integrates with the conjunctiva and acts as a great graft for volume for surface augmentation. Just a tiny tidbit here. For patients when you're doing surgeries to add volume inside the socket, expect some amount of ptosis to occur, but that's okay. You can always do a minimal ptosis surgery, and at the end, you'll have a much better outcome because you've replaced volume inside the socket where actually was missing, and it gives an excellent postoperative outcome. That is it from my end. Thank you very much.
Thank you, Darshini. Sabri, your pointers on the topics, please.
Yeah, thank you. Thanks, Shubhra. This was a really extensive session. Thanks, Dr. Prashant and Dr. Kasturi. Excellent set of photographs, Dr. Neelam. There was really not much that I can add. Just 2 points that for the general ophthalmologist, while the exposure to radiation with CT scan is there, it is minimal when you're just doing, say, one CT scan when it comes to orbital tumors. So do choose the right modality, especially in cases where a foreign body is suspected. You don't have to directly jump to, doing an MRI. A CT scan would be fine. The second thing is that just wanted to make a small note on MRI. The Dr. Neelam has covered everything. Even in cases of now nasolacrimal duct, any suspicions, there is a modality besides CT and MRI, which is basically high definition, sort of DCG, which you can do without actually injecting a dye. Coming to Tarjani's talk, Tarjani, it's always a pleasure to watch your videos and documentation and the little nuances of surgery. But in terms of the general ophthalmologist view, I would only like to say this, that it is important to know your assessment before and at least do a simple USG, which is what Dr. Neelam spoke about, before we actually go ahead and plan an enucleation or evisceration, so that we don't miss any possible intraocular tumor, because that would really mess things up. That's it. Thank you.
Thank you, Sabri. That was very, very precise. Next, move on to the next session. I invite Dr. Manpreet Singh, Dr. Neha, and Dr. Maya Hada on board, please. Dr. Manpreet is from PGI Chandigarh, and we have a budding Ocuplastic faculty, Dr. Neha and Maya from Jaipur. Over to you guys for your topics. Thank you.
Thank you, ma'am. Am I audible?
Thank you, Dr. Prashant, and okay. Thank you, Dr. Prashant, Dr. Kasturi ma'am, for having me on board. And I'll straight away share my screen for the topic. Thank you for giving me a lacrimal one. So is it visible? Okay. Evaluation of congenital and adult nasolacrimal duct obstruction is the topic. So I'll keep myself to evaluation part. Primarily, we have got 3 goals for lacrimal evaluation. The patient presenting with watering, we should try to differentiate, is it epiphora or hyperlacrimation? Second goal should be, is it anatomical obstructive pathology or a physiological one, which is non-obstructive pathology? And if it is obstructive, what is the site of obstruction? Is it the punctum canalicularis or NLD1? So let's get it right first. Why the patient is watering? Is if this gland is acting a bit more and the drainage system is fine, then we call it as hyperlacrimation. Patient will tell you that tears tend to stay in the conjunctival cul-de-sac, and I have got sensation of tear collection, and majority of them have got ocular surface pathology. And remember, like hyperlacrimation in these patients, we treat them majority with medical management. And while if there is an epiphora, that's where the drainage system is having an issue while the lacrimal gland is functioning properly. So the tears are overflowing, and the patient will tell you that there is actual need to wipe off from the tear trough. And as I've told that there is lacrimal drainage system pathology, and in majority of these patients, the management is surgical. That's why we should be able to differentiate by examination, is it hyperlacrimation or is it epiphora? So once we got it right, then history is one of the clinching part, which establishes the further diagnosis, especially in children having CNLDO. The onset will be shortly after birth or in the first 2 or 3 months. The frequency patient, the mother will definitely say it's continuous, it doesn't go off in between the days. That typically may be mucoid or mucopurulent. And if there is intermittency of the epiphora, then you may suspect stenosis, which worsens with URI, and patient may give you history, parents may give you history of intermittent increase in the watering. So what are the DDs in a child if you are tackling with? If it is having watering with this, which is having clear fluid, then suspect agenesis. You can have a good look, magnified look of the punctum and canalicular region. If the watering is with the discharge, and then majority of them have CNLDO. If there is watering with some amount of photophobia, child is not looking at you properly, or if you are trying to click a photograph, they are not cooperative, suspect a glaucoma can be there. Epiblepharon, there will be some issue with the eyelashes or eyelid margin. And if there is corneal or conjunctival issues, then there will be redness of the surface. So these DDs, keep it in mind in a child, at least when you are dealing with. So in a case where there is a unilateral watering of long duration with the discharge, epiphora is the reason. While there is bilateral aggravating relieving factors are there are symptoms, itching, foreign body sensation, redness on and off, with some medical histories, probably hyperlacrimation. In this slide, H is for hyperlacrimation, E is for epiphora. And if it's trauma, nasal symptoms, or surgery has already been done, then obviously it is epiphora. So while clinical examination, I want to make a point that always examine your patient while blinking. Examine the blink of the patient carefully. Is there any lag of ophthalmos? What is the tone of the eyelid? Tell them to blink normally, then with force, and have a look on the position of the punctum. If there is ectropion, like in this picture, you can see there's incomplete closure, there's lag of ophthalmos with retained tears. There may be facial nerve palsy. In clinical evaluation, raise tear film height or the tear film meniscus as compared to the other eye. If there is asymmetry or if there's unilaterality, then the diagnosis is relatively clear. Along with matting of eyelashes, matting happens because of the mucoid content of the tears. And generally, child doesn't allow complete wipe off, so that always will be there. It's kind of universal. And if child is cooperative enough and or probably old enough, you can perform Roplast test. And fluorescein dye disappearance is a simple test which tells about the, majorly about is the dye, is the pathway patent and functioning. So this is a FDDT. You put fluorescein drop in both conjunctival cul-de-sac. If there is a unilateral disease or asymmetric disease, it will give you more information. Just look at the left eye. There was dye which disappeared at 5 minutes, and in the right eye you can see the dye is still persisting. So there can be an anatomical obstruction or there can be a functional issue. So functional issue, always look at the patient's blink. Regurgitation on pressing lacrimal sac is also known as Roplas. Everyone, at least the cataract surgeons, know how to do it. Use the bud that will go better into the lacrimal sac fossa. It lies just beneath the medial canthus, and try to stay behind or below the medial canthal tendon. If the reflux material is mucoid or mucopurulent, don't do any cataract surgery. Indicates patent canaliculi and obstructed nasolacrimal duct. It doesn't only indicate that the nasolacrimal duct is obstructed, it always also indicates that your canaliculi are patent. So coming swiftly to lacrimal probing, it's a simple procedure, but should be performed diligently, and patient should be preferably in lying down position. Try to use upper punctum and canaliculus. Use a good, nicely tapered Bowman's or nettle chip or Wilder's punctum dilator. Use a Bowman's probe. First go 2 millimeter vertically, then stretch the eyelid and go horizontally. This stretching is very important. Same you follow for lacrimal irrigation. This step is followed for the lacrimal cannula. So why I was telling that stretch the eyelid, because in normal probing, if everything is fine, then you will feel hard stop because of the medial lacrimal sac wall, which is lying against the bone. If there is a soft stop, the probe is trying to push the obstructed canalicular tissue, and you will not feel the hard stop. If you're not feeling the hard stop, that is soft stop. And if you're not stretching, if you're not stretched the eyelid and you're trying to do probing, and you may have this kind of situation where the this soft stop is falsely positive. So try to use a straight cannula.
30 seconds left.
And try to use the straight cannula and avoid angled cannulas. This is how the diagrammatic representation of syringing is done, or lacrimal irrigation. Like in on the right side, okay. Right side, if you are injecting the fluid from upper punctum canaliculus, this arrow is pointing that it is going down. So this is nasolacrimal duct is patent, and this cross is mentioning that the punctum is obstructed. Hence, you are not able to. There is no arrow here. On the left side, you see this this nil written over the end of the nasolacrimal duct, and there's 3 millimeter. There's a straight vertical line that shows that there's a canalicular obstruction. If there is canalicular obstruction, try to mention what is the distance of it. This is how the documentation is done. And this is another one. If you have regurgitation, if there is written, Okay, last slide. So for a general ophthalmologist who is listening, if there is a nasolacrimal duct obstruction, this is a red flag. Don't do any cataract surgery. If the patient is having bilateral both upper and lower punctum obstruction, you can perform cataract surgery. So always look at the discharge. It's a blick mnemonic, and thank you.
Lovely. Manpreet, that was a beautiful coverage of all the pointers. I know it's a big topic and we are running a little late. I'm sorry to just remind the time. Next is Dr. Neha. Neha, can we have your talk, please?
Thank you, Dr. Shubhra, for the introduction. Is my screen visible?
Yes, you can go ahead, please.
Thanks, Dr. Kasturi and Dr. Prashant and Team ARC for this opportunity. So I'll be talking about congenital and acquired nasolacrimal duct obstructions and their management. And as we all know, the pathogenesis of CNLDO is that there is an incomplete canalization or an obstruction at the valve of Hasner. And in primary acquired nasolacrimal duct obstruction in adults, there is a generalized stenosis or narrowing of the nasolacrimal duct. This leads to stagnation of tear secretions, infection and inflammation of the lacrimal sac, and ultimately can lead to chronic or acute dacryocystitis. So the management of CNLDO is multi-pronged. It depends on the stage and the age at which the child presents, and it includes lacrimal sac compressions below the age of 1 year, syringing and probing beyond the age of 1 year, with or without additional procedures such as balloon dacryoplasty or silicone intubation. And if all else fails, then DCR needs to be done. So lacrimal sac compressions have shown excellent outcomes before the age of 1 year, and the likely resolution rate up to the age of 3 months is 90%, between the ages of 3 to 9 months is about 80%, and beyond the age of 9 months up to 12 months is about 75%. And it's also important to do the sac compressions properly. The correct technique should be taught. So in a large study of more than 1,200 eyes with CNLDO, it was found that about 129 patients were not doing the syringing, the sac compressions properly, but after they were taught how to do it, then about 61% of them resolved with Cridler's lacrimal sac compressions. So let us just look at how it is done.
Is to hold the child firmly, hold the head, and make sure the head does not move while doing the compressions. Now use your index finger to do the compression. Make sure that your nails are trimmed. Feel for the edge of the bone next to the nose and below the eye. Using firm pressure, gently press towards the nose, directing the force slightly inwards. Continue these compressions 10 times per sitting. At least 4 such sittings per day have to be performed.
This lacrimal sac compression should also be demonstrated on the mother so that she can understand the amount of force that has to be applied. Now, next coming to irrigation and probing. So probing has also shown good results even up to very late presentations of up to 5 years of age. But however, these good results drastically reduce when the child actually has a complex CNLD obstruction as compared to a simple CNLDO. This is the video showing how to do irrigation and probing. So it's done under general anesthesia. The nasal mucosa is decongested using 0.025% oxymetallazoline drops. The upper eyelid is everted using the index finger at the junction of the medial 1/3 and the middle 1/3. A rapid taper punctum dilator is used to dilate the puncta on both sides. Thereafter, a 23 gauge metal cannula is used to perform irrigation, first on the unaffected side and then on the affected side. Thereafter, we have to take an age-appropriate probe. We have to pass it through the upper punctum, through the canaliculus, and pass it until we hit a hard stop. Once a hard stop is felt, then the probe is then made vertical, and it is passed downwards through the nasolacrimal duct in a downwards, lateral, and backwards fashion. Then we take the blunt end of a periosteal elevator and we insert it into the nasal cavity, and we elevate the inferior turbinate to be able to see the inferior meatus well. And the probe is advanced and the membranous obstruction is overcome. And the periosteal elevator is taken and it is used to elevate this probe and increase the size of the nasolacrimal duct opening. After this is done, we have to repeat the syringing with fluorescein stain dye, and we should be able to see the dye flowing freely in the inferior meatus. So the most common causes of failed probing include blind probing without endoscopic guidance and also complex CNLDO. Indications of early probing in certain cases include congenital dacryocystocele, which predisposes to acute dacryocystitis. Acute dacryocystitis and lacrimal abscess is, of course, an indication of early probing regardless of the age of the child. And also chronic discharge not amenable to sac compressions are also an indication. Endoscopes are generally expensive. So for general ophthalmologists out there, there are multiple options that are available. Digital otoscope cameras can also be used easily for outpatient procedures, and even nasolacrimal duct obstruction for syringing and probing. Portable nasal endoscopes are also available in various sizes and shapes and price ranges. So now let's just quickly move on to the acquired NLD obstructions. Primary acquired nasolacrimal duct obstructions, which are symptomatic, have an incidence of about 30.47 per 1 lakh population. And since this is targeted towards general ophthalmologists also, we should remember that this is the age group in which a significant proportion may also have cataract-related vision impairment. So it's important to remember that concomitant chronic dacryocystitis is a risk factor for development of endophthalmitis if cataract surgery is done in these cases. And the jury is still out on how to do SAC evaluation prior to cataract surgery. Some people say syringing and some people say Roplas is enough. And a study recently by Shenoy et al., which compared syringing and Roplas, did not show any significant difference in the endophthalmitis rates after SAC evaluation was done with either of these procedures prior to cataract surgery. Also, I would like to put across here that common canalicular obstruction is not a contraindication to cataract surgery. So acquired nasolacrimal duct obstruction, of course, has to be treated surgically unless there is an acute dacryocystitis, in which case medical management is done, followed by surgical management. Surgical management may include dacrocystectomy or dacrocystorhinostomy, which is the most common procedure. External DCR is the most common DCR procedure performed in India. Endoscopic DCRs are also performed. There is a variant called non-endoscopic endonasal DCR and endolaser DCR. DCTs are done only in very old and debilitated patients and should be done in cases needing urgent intervention like bilateral total cataracts or lens-induced glaucomas or microbial keratitis. All the rest of the time, we should choose DCR surgeries. Here is a patient with an acute acquired lacrimal fistula in a setting of acute dacryocystitis. Here, I'd like to point out that it's not necessary to do a separate fistulectomy. When we do an external DCR, and if we take the incision through this lacrimal fistula, then it is sufficient and it will heal after post-DCR.
Neha, you have just 10 seconds, please.
Okay, so I'll just quickly go through all of these. It's just important to remember that the anterior extent of the ostium that we make in the DCR is till the bone raunchure can no longer be insinuated between bone and nasal mucosa, inferiorly until bony NLD is partially deroofed, posteriorly up to the lamina papricia of the ethmoid bone, and superiorly 3 to 4 millimeter above the medial canthal ligament. And also, this is important, the nasal packing post-DCR and pre-DCR are different. The nasal packing pre-DCR has to be in the area of the middle meatus, whereas in post-DCR, we don't go all the way up. It's just to for hemostasis, and deeper packing should be avoided. There are multiple other important topics that we have to cover, but because we don't have enough time, this is just a panel showing the outcomes in both middle-aged ladies having acute dacryocystitis with external DCR and endoscopic DCR. And now we can clearly see why endoscopic DCR is preferred by many surgeons.
Thank you, Neha. Thank you for a wonderful, I know it's a big topic again. Sorry to interrupt at 8 and people are getting tired. It's 10 o'clock. Maya, over to you for your tips, please.
So very elaborative talk, both Manpreet and Neha. Just a few important points I would like to stress upon. First, that as Neha said, the need for educating mother how to do a correct method of regular sac massage, because most of the times these patients, they are just doing skin rubbing and they're not putting enough pressure on the sac inward to increase the hydrostatic pressure inside and to push the membranous blockage. So it's very important to educate them about the correct method of this massage. Then secondarily, again, as Neha said, that primary probing, it should be done very meticulously and in correct way, and that for that it is important to know the correct anatomy of the NLD, correct direction in which your probe is you are passing the probe. And the third thing I would like to tell that when the ROPLAS is positive, then you not need to do syringing, because most of the time these patients, they come to us with canalicular blockage. They have this history of so many times they have undergone syringing by ENT surgeons or by other ophthalmologists, and that can lead to iatrogenic damage to the canalicular. So when the ROPLAS is positive, don't do syringing. So these are my 3 points that I wanted to say.
Lovely, Maya, as always, great. Dr. Lakshmi, can we have you on board for some of the closing remarks and also the tips on various topics which were discussed, ma'am, if you're there?
Lakshmi ma'am, are you there? Wait, let's check. Madam, are you there, Lakshmi ma'am?
Dr. Betharia is there. Sir, can we have you on board for the closing remarks, please? Neha, can you just go your off screen for your presentation? So you are on mute.
Are you getting my voice now?
Yes, sir.
Regarding this pressure massage, which we have to give to the children in congenital dacryocystitis, the idea is not to create regurgitation, but we must block the puncta and canaliculus and then push the contents to open the nasolacrimal duct, lower end of the nasolacrimal duct where the block is there. So this part is very important because many times the mothers are not doing it properly. So if it is done properly, then most of the times the syringing probing can be avoided. So that is very, very important in congenital dacryocystitis. Other topic on which you want my comment? Any other thing?
Any other tip if you have to give? Otherwise,
yeah, I think I have enjoyed the session very nicely. It has been a long session for me because 3 hours I am sitting with you all. So my suggestion will be the session should be of about 1.5 hours, which we can prolong it up to 2 hours. But don't keep the session more than 2 hours. That is my humble suggestion because it is very tiring. And if the session becomes long, nobody is able to concentrate that much. So I think it is better to have session of 1.5 hours and prolong it to 2 hours by giving some half an hour more. So I have enjoyed this session, but the session was too long. That is what is my impression about this session. Thank you very much.
Thank you so much for the kind words, sir. Plasty always continues 4 hours because very difficult to, request everyone.
Because there is no end, Kasturi. There is no end because our topics are so vast. And, as you grow older, you can summarize it better. You can summarize things in a very small way. And younger people, they want to talk more. So this is the thing, the difference between an experienced person who can just summarize and tell you 2, 3, 4 points, which are very, very important practically. Otherwise, we keep on showing the pictures and all that and talk theory. But this particular thing, we need to talk because we are just telling it to the people who are new, who have not done much work. And this is for general practitioners or like that. So we have to clear the basic. So I understand that. But later on, whenever we are talking for oculoplasty people, there is no need for again revising anatomy or touching the basics. We should tell some important 4 or 5 points which you have learned out of your experience, and that is going to benefit all of us. Thank you.
Thank you so much, sir.
Much for the kind words. So I think with this, we come to the end of today's session. I would like to thank all the chairman, co-chairman, Dr. Shubhra, who moderated the session so well, all the speakers, all the discussants for the very excellent inputs that though we are all like, veteran oculoplasty surgeon, but so much to learn from every, presentation. All presentation has been done very wonderfully. I really appreciate all the discussion, and thank you, Dr. Prashant, for giving us the opportunity to have this webinar. I understand we had exceeded time, but plasty is so interesting. It keeps on going. Like there's always a complaint. Plastic, session goes for 4 hours, but definitely as Biteria sir has mentioned, next time we'll have more of case presentation and the debates, and we'll keep it within 1.5 hours. So thank you, sir, for the kind suggestion, and thank you all of you for being with us, and wishing you a very happy dinner and a very happy weekend.
Thank you, madam.
Thank you so much.
Thanks.